Hello, a very good day to all my friends out there. Is my voice audible and clear to all of you? Can you all hear me?
Yes, Dr. Sidra.
Thank you, Dr. Bindu. Hello, Dr. Dipti. Hello, Dua. Hi, Nadra. Hi, Dr. Sabia. Hello, Dr. Sujata. I hope you all are fine. And friends who are yet to join, please join in as we are starting again a discussion on gynecology today and two stations from urogynecology and postpartum as well. Thank you very much, Nadra. Hello, Dr. Sabia. Thank you very much for joining in. I hope you all are doing great. In the last 2 weeks' time, we had few news from the last students who just appeared in January. Two of my students, they appeared out of 28, and the best thing was that none of the station was a new station. Every station was a repeated station, even the renal transplant, the structured discussion, everything is what we have discussed in detail. So around two are appearing in March as well. I will give you guys the list of the stations and we'll add these stations in your PDF as well and in the March as well. Now, if at all the May examination is an online examination, you all should be ready. You all should be ready to pass this exam because this is going to be a golden opportunity because of this unfortunate pandemic situation. It's settled. Of course, it's going to go back to the on-site thing. So whosoever is going to take advantage of this thing would definitely be beneficial for all of us. All right. Thank you very much, Dr. Sujata. Dr. Bindu, please drop in a message in the main group that we are starting so that if somebody is waiting, we can begin. Thank you very much. All right, so it had been a long journey starting from sexual and reproductive health, and we did urogynecology in the last session together. It was gynecological problems today. We are going to do 6 stations out of that, and 2 stations we are going to cover up from the last ones as well. Thank you. For all the presenters, please read carefully, be a fast reader. Please pick up the buzzwords, the important words which give you the hint. 1 minute for reading and 1 minute for making the outline so that you're confident inside the cubicle. Now, what do we expect out of the gynecology module? Now, when it comes to the gynecology module, there are certain important topics like premenstrual syndrome 3 or 4 times has come up till now for different types of in different days in exam, and dysfunctional uterine bleeding, heavy menstrual bleed, fibroid. The counseling on uterine artery embolization and on endometrial ablation generally doesn't come as a whole, but it does come as tiny part of the station where we need to counsel the patient for this specific technique for treating the heavy menstrual bleed. Dysmenorrhea, primary amenorrhea, secondary amenorrhea, polycystic ovarian syndrome, premature ovarian insufficiency, hirsutism, bladder pain syndrome, menopause, counseling on HRT. Postmenopausal bleeding is overlapping with oncology as well. We are going to do this station in oncology. The chronic pelvic pain, endometriosis, vaginal discharge, we'll do 1 station today. Intermenstrual bleed, dyspareunia, pelvic congestion syndrome, and sexual assault as well. Benign ovarian cyst, pelvic inflammatory disease, tuber-ovarian abscess, ovarian cyst excidents. There can be benign vulval problems, vulvodynia, lichen sclerosis that comes in the overlapping with the oncology pre-malignant lesions. We've got certain congenital anomalies as well, which we will be discussing, specifically vaginal septa that comes in exam. Along with that, the androgen insensitivity syndrome twice or thrice came in the mock exam, never came in exam up till now, but you should be knowing about the counseling of androgen insensitivity syndrome as well. The patient information leaflets. We've got plenty of them from the college, and the rest we do from the NHS source. And up till now, you people are master in knowing that how we have to use the patient information leaflet. All right, so we discussed the basic template of the gynecological problems, the basic template we did from the gynecological problems, the history taking introduction agenda history, the complaints menstrual irregularity. If it's a menstrual irregularity, you take an HOPI complete history, please. We are going to practice 1 station today. If it's a discharge, you take its history first, then you go to the complete template of your information gathering. You do the dysmenorrhea history In HOPI, then you go to the complete template. Similarly, dyspareunia questions you all know, postcoital bleeding questions you all know, intermenstrual bleeding you all know, menopause, wanting HRT you all know. Then we are going to cover the gynecological history, the obstetric history, the medical history, family history, surgical history, drugs, allergies, personal history, social support, and how had she been feeling in the last few weeks, examination, management, addressing concerns, and the closure. Now we had a request here. Dr. Dipti had to go for a duty. So can we exchange Dr. Dipti and Dr. Sujata? So Dr. Sujata, is it all right that Dr. Dipti does the first station? If it's okay with you, please. You can do the third.
Okay.
Okay, I'm really grateful, Dr. Sujata, for cooperation. Thank you, dear. Okay, Dr. Dipti, can we check your mic?
Hello, Dr. Sidra.
Hello, how are you doing?
Yeah, I'm fine.
Okay, that's
How are
good.
you?
No, I am fine. Thank you very
Yeah.
much. All right, so we are going to begin with the first station today, and then we'll take Dr. Fozia and then Dr. Sujata. So we'll switch over. Dr. Dipti, what are you
Yes,
getting
yes.
today? What is the station we are discussing, about to discuss?
Maybe HMB.
You are thinking that Sidra was going to give you such an easy station? Yeah? All right. So let's see, what do we have? Dr. Sabiha, you're not on duty today? Dr. Atya, hello, you joined in? It's Friday. It's your day, a holiday, a weighted holiday of the week. Yes? I hope you joined in. Thank you. Everybody, please be active. Oh, okay. Thank you very much for the hello. I was waiting for your hello, Dr. Atya. Thank you. And don't you people think, see, 2 sessions are left, and I would be strict even when the sessions are over because we have to cover around 4 books. In fact, 5 books if we add Dr. Kunja's book as well. Students who finished up Dr. Atya in April and in March, they started the next book. So we have to cover after the exam station. The pattern would be that you people would revise from the recording one module and one book we are going to cover, start it from cover to cover. So you won't be having time. Completing 5 books means at least 2 months. Okay, at least 3 months time. So all of you, please, you're going to get up because I will give you the schedule, day-wise schedule, that what are the stations you people are doing, and whenever you people will be stuck up in books, so the mini groups would stay like the same way in the practicing zone. Okay, so you all have to get up even the exam stations are over. We are going to start the book. From the first book we would be starting, and one after the other we'll complete the books and we'll come to the revision. Okay, schedule I'm going to provide you for that, so nothing to all right. Okay. So let's begin to Dr. Dipti. I know the pulse would be around 100. Am I right, Dr. Dipti? Yeah?
Yes, more than that.
More than that. Okay, let's begin. Go ahead, Dr. Dipti.
Yeah. Next slide, please. Any other slide, ma'am?
No, that's it.
Okay. Should I start?
Yeah, I'm waiting for this.
Yeah.
Just hold on. The time is over, but it didn't ring. I'm just fixing the timer. Just 1 minute. Yeah, now it's fine. Okay. Yes, I'm
Okay.
starting 10 minutes now. Please go on.
Hello, I'm Dr. Deepti, ST5 in the NE today. May I confirm your name and age, please?
Doctor, I'm having severe pain in the lower tummy. Doctor, I could not pee since morning. Please help me out.
Yeah, I can understand your problem. But I'll ask my staff to help you in that to help you to go to the washroom. But is that
No, no,
okay?
it's not that I cannot go to the toilet. I can go to the toilet, but I cannot pee. Please help me
Mm,
out. It's
yeah,
pressure in
yeah.
the lower tummy.
Okay, yeah, I can understand, and I will put some rubber tube to relieve that pain and to drain the urine. Is that okay?
Please do that urgently.
Okay, and I'll also give you some painkiller. Are you allergic to any medicine?
No, I'm not, doctor. Please go ahead.
Okay, okay. Uh, are you okay now?
I'm feeling better. Thank you very much, doctor.
Okay, now can I confirm your name and days, please?
Yes, doctor. I'm Julie Mullins. I'm 39 years.
Okay, and how can I call you?
Yeah, Julie is all right.
Okay, Julie. So as I come to know that you are unable to pass urine since morning and have pain in abdomen in your tummy also. Is that okay? Is that right?
Yeah, exactly, exactly. It's since morning that I'm having lower tummy pain, and I could
Mm-hmm.
sense that I had an urge to pee, but I could not pass pee. I mean, there was some sort of a blockage. I don't know.
Mm-hmm. Is this the first time you feel like that, Julie, or
It's
before that also?
very very first time.
Okay, Julie. Julie, do you have any problem while opening your bowel?
No problem with the bowel, doctor. I had it yesterday.
Okay, and Julie, and um, yeah, I can understand your concern, Julie. And in next few minutes, I will address all your concerns, and definitely we come to a safe and mutually agreed plan for you. Before that, I want to ask you a few questions. Is that okay?
Yeah, that's okay.
Okay. Do you feel any heaviness in your tummy or down below?
Yes, exactly, doctor. Just wanted to talk to you about that. It's been around 5 months that I was feeling that my tummy from the lower side that's getting bigger, and in the last 2 months, I've thought that it's not even of that earlier size. I mean, it's growing even further more, and
Mm-hmm.
now I can feel something hard on my tummy. If you just touch it here, you'll feel that something hard is inside.
Mm-hmm. And do you feel pain before also
Pain in where, doctor? In the
in
tummy?
your tummy? Yeah.
It's not exactly pain, but it's like stretching. Now I feel that it's the tummy is being stretched up.
Okay, and Jilly, are your appetite is okay? Are you feeling bloating or any change in your appetite behavior?
No, the hunger appetite, that's absolutely fine. But I
Okay.
with the same type of tummy swelling, I felt the same that I had the periods heavy. I never
Mm-hmm.
had this issue, but now I feel that my periods for the last 3 months, I'm passing clots as well. They come on the
Mm-hmm.
same date, doctor, but I am using more pads than I was using it earlier, and I have flooding as well.
Okay, okay, Anjali. And do you feel bleeding in between your periods also?
No, doctor, the
No.
the cycle is regular.
Okay. And have you noticed any bleeding after having sex?
Doctor, it's been around 6 months. I'm not sexually active actually.
Okay, okay, Jilly. And Jilly, any discharge from down?
No, doctor.
Okay, Jilly. So when was your last period?
Yeah, that was around 2 weeks back.
Okay, and before 3 months, how was your periods?
Uh, Around 4 months back, I used to have
Mm-hmm.
regular periods. Still, I have
Mm-hmm.
regular, but the flow was normal as well. I mean, first 2 days, I used to have a little more, and then it used to
Mm-hmm.
like lessen. But now I
Mm-hmm.
feel that in even 5, 6 days, I'm having clots, and I have to
Mm-hmm.
wear a double protection. Even then, it's flooding.
Yeah, yeah, I can understand your concern. Do you feel have pain during your periods?
No.
Okay. And are you using any contraceptive method?
Yeah, as I told you that I'm not sexually active, so I'm not practicing.
Okay, okay. Jilly, have you ever been pregnant before?
Yeah, I've got one kid, and he is fine. He was a cesarean section.
Okay. And any problem during cesarean section and after that?
No.
Okay. Jilly, are you updated with your smears?
Yeah, my screening has been going fine
Okay. So when was your last smear?
last year.
Okay. Julie, are you following your GP for any other medical condition?
No, I'm okay, doctor.
Okay. Any, are you taking any medicine right now?
No, no, not exactly.
Okay. Any drug allergies?
No,
Any surgery in your tummy or down below in past apart from your cesarean section?
only cesarean section.
Okay. Is there any family history of concern like cancer of breast or cancer of intestine or ovary in the
Nothing,
family?
nothing like that, doctor.
Okay. Julie, do you smoke?
I do that occasionally.
And alcohol?
Yeah, that too occasionally on gatherings. That's it.
Okay, and pardon me to ask, you use any street drugs?
No.
Okay. Julie, what do you do for your living?
Yeah, I work as a teacher.
Mm-hmm. Okay. Julie, how's support at home?
Yeah, that's fine.
Okay, and how do you feel in last 1 month?
Everything was fine. It's just about since morning I was having this trouble, and I have a little
Yes, yes,
discomfort because of this tummy swelling. That's it,
y-
doctor. Otherwise, I'm all
yes,
right.
yes. So, Julie, have you underwent any medication or any investigation because of this problem in the past?
No, not yet. But today, just an emergency, they said that they'll plan an ultrasound.
Yes, okay, Julie. Julie, are you aware of your height and weight ratio?
It's 23, doctor.
Okay, Julie. Julie, so as I have come to know that you are having the pain and you are getting retention of your tummy, and also you are having heavy periods for last 4 months. Anything else you want to add in this?
That's it.
Okay, Jilly. I want to examine you in the presence of a chaperone. I will check you for general health, your pulse and your blood pressure. And as my nurse has already examined you from the tummy, I will also want to examine you from down. I want to do that the checkup from down also. Is that okay?
That's fine, doctor.
Okay. Jilly, yes. There's some swelling in your lower tummy. There's some mass in your lower tummy, which is around till your mm, uh, till your navel, and it is because of this mass. There might you might have feel that you are unable to pass urine and you have pain. So I have to do some investigations for you. I have to arrange the ultrasonography for you so that we can come to know what is this mass, from where this mass arises, and accordingly we'll go for your options. Is that
Yeah,
okay?
I understand, but where is this swelling coming from?
Actually, this swelling, as from examination, we can't come to know that from where the swelling is coming on. It can be from your womb, it can be from your ovary, or from it can be from any other abdominal any organ inside your tummy. The masses can be from anywhere, so we have to do the scan to rule out where this mass is arising from. And because your periods are heavy, so I'm thinking that your mass must be arising either from your womb, that we called as a fibroid. So these fibroids are basically because you are having heavy periods for last 4 months also.
Doctor, is it a cancer?
No, Jilly, these fibroids are not a cancerous one. Sorry. These are not cancerous one, don't worry about it. But because the size of this mass is too big, so we have to check out whether what are the changes because of this fibroid is happening, because whether it is causing any pressure symptom, any because of this mass, if there's any pressure on your kidney or on your bladder. Am I clear, Jilly?
I get that, doctor.
So Jilly, I'm appointing for your scan, and I also inform my consultant for your condition. And after getting this scan report, I'll come to you, and definitely I'm here if you want anything. Is that okay?
Thank you very much, doctor. Thank you.
Okay. Okay. So I'll send you for the scan. Yeah, thank you for your
Thank
time.
you very much. Thank you. How is it, Dr. Dipti? Oh, you're having a sore throat, huh?
Yeah, actually.
I can understand. No problem. Please do take a little honey water with slight ginger. It really works.
Yeah, yeah,
Yeah.
yeah.
Okay.
I'm taking
All right.
it.
Get well
Yeah.
soon. All right. Okay, friends. Dr. Atia, Harshiba, Dr. Abir, Dr. Sujata, Dr. Sabia. How did the station go? If you would have been at this place, what change you would have done? Dr. Dipti, how was the station?
I'm not. Mm.
No, 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 no. Tell me the good points first. You know me. I always want the confidence first. Please tell me what good did you do? Abir is really.
Uh, yeah, I have addressed her concern that she's not able to pass urine and she's
Yeah,
in
that's
pain.
fine. Yeah, yeah.
So
Very good.
that thing. And later on, I confirm her name and age because.
Very good. Very good. Yes.
And
Okay. All right. Let's talk to others. Dr. Atia, if you would have been at her place, anything different you would have done? Dr. Sabiha, please, everybody, please be attentive. Don't tell me that you guys are doing multitasking. Yes, yes, yes. Okay, okay. So Dr. Abir is also having flu. Okay, no problem. No problem, Dr. Abir. May you get well soon. All right. So, organized history taking, Diana, definitely it was. Dr. Sabia is on duty. Okay, Dr. Sabia. So I am forgiving you for this, but whenever the patients are not there, please let me know. Okay, I'll take you actively. All right. Okay, okay, I understand. Yes, history was a little. It went little 6 minutes. I understand. Yes, and yes, Dr. Bindu, she was very considerate to the patient. Okay, Dr. Sabia, please keep on listening. That's something which I really want. And management to be addressed. Yes, Dr. Sujata, that was something. I was waiting for the management. At least it is a sure shot case of fibroid, though you have to do ultrasound, but you have to tell about the management plan as well. Right? Yes, Dr. Bindu. Thank you very much, Fawzia. You know, Dr. Fawzia, I had to say that yes, I have a little discomfort in sex as well. But when Dr. Dipti immediately said that, do you have any problem with the sex or bleeding after the sex? I immediately said that I'm not sexually active. I had to say that just to make her realize that always do signposting. Otherwise, it was like I am basically I was in an instruction, I was sexually active, but because signposting was not done, I immediately changed my answer. So always do a signposting. Never assume that your patient is sexually active. Okay, always do signposting. Thank you very much, Abir. All right, so let's go to the feedback, friends. So when Dr. Dipti entered into the cubicle, she wasn't expecting Jilly to be in agony. So immediately there was some fumbling. Yeah, when you go back to the recording, you people would realize that it was a fumbling. She said that she has given the painkillers, she ruled out the allergy, she passed the rubber tube, so that was all good. A little fluent, I would expect in future after practice. So don't fumble if you come across in an emergency, right? I did thank you for making me feel better. Then you confirmed the name and age, Jilly, 39 years. Information gathering, you started with an open question. You asked about other bowel complaints. There were not any. You did ask about the pain in the tummy, appetite, about HMB, about intermenstrual bleed, about the postcoital bleed, about the discharge, about the last menstrual period. Then you did ask about the contraception, about the surgery, medical history, family history, allergy again, that was repeated, smoking, alcohol, about the support system, and about her profession as well. You did examine, that was all right. And then you came to telling me about the management plan, which was only ultrasound. So I was expecting an information leaflet in the end as well. So these were the good points. So what are those points which we could do better? Now, the first thing is that, see, Dr. Dipti, if the patient is in emergency, so it's okay that you handle with a soothing voice or a quick voice, but not fumbling. When you'll go to the recording, you'll understand that there was lots of fumbling in the beginning. That was why, because you were not expecting. All of you, please listen to me very carefully. Who is listening to me? A thumbs up, please. Who is listening to me at the moment? Thumbs up. Yes, I'm waiting. Thank you. Whenever you guys enter into the cubicle and outside the cubicle, it's written A and E. When it's written A and E, that means that you're expecting some sort of an emergency inside. So that should alarm you outside. Okay, you should be mentally prepared that you might have to settle the role player inside. Okay, so rather than saying ST5 A and E, how we are going to say that, Dua, Nadra, Abir, we have to say, hi, I'm Dr. Dipti. I'm one of the doctors covering emergency today. So may I confirm your name and age? Now the name and age doesn't come up. I can see that you are in difficult situation. You're uncomfortable at the moment. I've just called the nurse to pass the rubber tube to drain the bladder. Would that be okay? I would also ask her to give you painkiller. Do you have any known allergy? Take 15 seconds pause. Is it okay to continue now? May I confirm your name and age? Can I call you Jilly? Thank you. Jilly, I'm going to ask you quick questions to know more about you, and then we'll come to the management plan. Would that be okay? Did you people see the difference? A continuous flow without fumbling, without making her know that, see, I am troubled. Don't tell the examiner, oh my God, I'm confused. Okay? Don't tell the examiner that I'm confused. You have to give an impression that you are sound in handling an emergency situation. And how do you come to know that? Because outside it's written that it's an A&E. So rather than saying I am an ST5 covering A&E today, you can say I'm one of the doctors covering emergency today, right? So I've written in the first 1 minute, there was lots of fumbling. You all have to ensure this doesn't go for Dr. Dipti, it goes for everyone, please. In an emergency situation, I want a very solid, a composed, and a confident voice from all of you. Okay? Rather than saying my staff would come, this is generally, we all must be practicing in different hospitals in our countries, but you all have to say that I've just called the nurse to pass the rubber tube to drain the bladder. Okay? So one thing which was like, I will help you to go to the washroom, that has to be avoided, Dr. Dipti. We will replace that because that's not required. It's a short urinary retention. Okay?
Yes.
So she doesn't have a problem in walking. She doesn't have a problem to go to the toilet. And again, if you remember Urogyne, I told you guys that when we say washroom, it is about bathing. When you have to talk about PO, for that matter, passing stool or poo, it is toilet. Okay? So we say whenever you have to use this word for this reason, you all would use the word toilet rather than washroom. Okay? Now, now I have written that never assume. It doesn't go for Dr. Dipti. It goes for everyone out there. Please do not assume that your patient is actually active. Always do a signposting. So if I would have been at your place, I would have rephrased it as, Judy, my few questions might sound a little intrusive and personal. Can I proceed? Are you sexually active at the moment? So may I know, do you have any discomfort during the sex or any bleeding after the sex? So now it will be okay. Right? So these 3 lines you all have to cram up, please, and you have to practice. Never directly say, do you have any bleeding after the sex? Because she might not be. We don't have to assume. First, confirm that she is sexually active. Second, confirm any discomfort in terms of pain or in terms of bleeding. Clear, everyone? Okay. Now, I had told 2 other batches as well. My November, December, January batch, they are currently going. Because of the change in the NHS system, we have changed our question as well about the cervical check, right? So rather than saying that, may I know about your cervical screening? Because the smear, you said cervical smear. because now in half of the systems the smear is not being done. In half of the systems it's been changed to the HPV triage. So I would request all of you to change and rephrase the question. How would we ask now in exam? May I know about your cervical screening, not cervical
Okay.
smear? Am I clear? Why would we say cervical screening? Because if she would be having smear, she would say yes. If she is having HPV as a test, she would be saying yes. So cervical screening, we would say, rather than may I know about your cervical smear and are they up to date? Because at a few places now smears are not being done. So we'll rephrase our question according to the NHS shifting. Am I clear, everyone? That how would we change our question? We would say, may I know about your cervical screening? Okay.
Great.
So screening word covers up both, so it's a safe word to use in exam. Now, if you've asked about the allergy in the beginning, we can omit that allergy thing in at this point. Okay, we can leave that at
Yes,
this
yes.
point. So it was a second time asked. Why did you ask that? I know, because generally in the template allergy comes at this point. Yeah. So
Yes.
it was in a flow, Dr. Dipti. I respect that. Okay. Now, examination as nurse has done. If you wanted to do the vaginal examination, that was all right. But otherwise, you can simply say that as my nurse has examined you, and you said that it's a swelling, it's a mass which is coming to the navel. So easy word or a layman language which is easily understandable by the patient is till the tummy button or the belly button. It's above
Okay.
your tummy button or it's above your belly button,
Oh,
like 20 weeks cut off, right? So this is an
yes,
easy
yes.
thing which you have to say to the patient, that it is a tummy swelling coming from below down and it is reaching the tummy button. It is above your tummy button. This is how you have to say.
Mhm.
There was little fumbling when I said, oh, doctor, is it a cancer? When you said about fibroid.
Mhm.
So anybody who could explain what fibroid is, how we are going to say that to the patient? Yeah, there was a little fumbling Dr. Dipti was having when I said that, what is, sorry, doctor, is it a cancer? So you have to say, no, it's not a cancer, Jelly. It is an innocent growth of muscles of the womb, which generally causes heavy bleeding in patients. Clear? Everyone, how
Mm.
do you, thank you very much. Dr. Bindu, just add word innocent. We'll do oncology and I'll tell you this is how I used to explain the benign thing and the malignant thing. Whenever we are talking about a benign thing, what we say is it is innocent. When we say innocent, so patient is satisfied because the word innocent in the English dictionary, that means that something which is not going to harm. Okay, so you say this is an innocent growth from the muscles of the womb, and generally it causes heavy periods in the patients. Clear, everyone? Point noted. Whatever I'm saying, you people are noting it down, right? Yeah? Okay. So then I was expecting PIL. So just give me PIL at that time. And that was the points which we have to improve together. All right. So let's see the examiner key and let's see how am I going to explain the condition to the patient. Thank you, Abir. All right. So when it comes to communication with the patient, because of fumbling, Dr. Dipti, I can understand that because a little health today was also not very well because in terms of flu and of course the voice was a little shaky. So I will give you borderline in communication with the patient because of two reasons. Number one, there was a little fumbling in handling the patient. And number two, I wanted a little better explanation of the condition, which I'll just tell you in a bit. Okay. And coming to the information gathering, this is the domain you did really well. There were 2 by 2 in history of presenting illness. I've given you guys a table here. So that table means that just one question out of this, like urine, lump, meds. Like, since when are you having this problem? Dr. Dipti clearly asked me. Since when are you having this swelling? And do you have any shortness of breath, any upper tummy pain? Uh, these all myths, confusion. You can ask just 2 questions out of each. Why did I make a table for you guys? So that you people don't have difficulty in finding out the questions. Abdominal pain, you do ask about. Then you ask about the last periods, the heavy periods, and about the dizziness, fainting. So they were all accurate questions in Dr. Dipti's information gathering. She did ask about the pressure symptoms as well regarding the mass. So with a pelvic mass, When it came in 2019, November exam, students were that, ma'am, it was a pelvic mass and we were confused whether it's a cancer or not. So there was no problem with the appetite. There was no problem with the any symptoms in terms of a cancer, but it was HMB along with a pelvic mass. So it was sure shot going towards the fibroid. Okay. So then you did complete your history template and you did examine as well. So this is a domain which did take marks complete 2 by 2, Dr. Dipti, but again, I would suggest that try to squeeze it into 4 minutes time, because then it takes your management time, my dear. Okay. Questions were complete, but
Yes.
the time was a little more, my dear. So I would request
Mhm.
just shrink it to 4 minutes time so that we have ample time for the management.
Mhm.
Now, what I'll do is, as communication with the patient, I said that I'll give you borderline. Reason is that I want a better drawing, because as a patient, I do not know what's inside the pelvis. Okay. So what I'll say is that if you follow this diagram, this is the bladder, which is in front of the womb, and this is your back passage, and this is just behind the womb. This is the womb and the tubes and the ovary. So generally, the growth or this mass can be from any part in this lower tummy. However, with your heavy periods and the swelling and the lump rising from the lower part of the tummy, generally it is going to be an innocent growth from the muscles of the womb. We call it as fibroid. However, we are going to confirm it on ultrasound, and then we are going to guide you about the confirmed diagnosis. Would that be okay? So now I'm telling the most probable diagnosis, and I am telling about the management plan now, because management plan was totally missing. Generally, because of the reason that you're unable to pass the P. That means that there's some sort of a blockage which this fibroid is causing. Therefore, we need to admit you and keep this tube inside until and unless we are sure that you're able to pee. Now, the management option is going to be according to the team of doctors. We have options of expectant management, wait and see, for patients who have this innocent growth from the muscles of the womb. However, it is unlikely in your case because it is causing symptoms and you are not able to pee. We do have medical management in terms of some medications which reduce the bleeding, or we have got some injections which shrink the size of the fibroid, following which we can plan the surgery as well. There's a specialized imaging doctor who can pass certain particles through the vessel from your leg and can shrink the size of the fibroid, so the pressure symptoms like that of blockage of the tube which is connecting from the kidney to the bladder that is being obstructed and you're unable to pee. In reduction of the size of the fibroid, that might help you in your symptoms. If you plan a surgery because of these pressure symptoms, there are two ways: either removal of the fibroid, either through the keyhole surgery or through the open surgery. The keyhole surgery would be less likely because of the size of the fibroid, or if you do not desire your fertility in future, with your choice and consent, removal of the womb can also be one of the options. Am I clear, Jilly? All these options would be discussed with you after the ultrasound is done and we are confirmed about the diagnosis. Would that be okay? At the moment, I'm going to admit you and we are going to plan an ultrasound. We'll give you patient information leaflet regarding the condition for detailed understanding. Do you have any concerns? Would you like me to repeat anything? Dr. Dipti, am I clear? Yeah?
Yes. Yes. Yes.
This was the applied clinical knowledge which I wanted, because otherwise the applied clinical knowledge would go fail.
Actually,
Harshita? Yeah, yes, my dear, please. Yes, Dr. Dipti.
I got confused. I was thinking of fibroid. I was thinking of ovarian cyst also. So that's
Why with HMB? Why with HMB you're
yeah,
thinking
yeah.
ovarian
So
cyst?
actually, I was thinking maybe some that hormone releasing tumors because she is 39. That.
When you asked about the malignancy questions like appetite or losing weight,
Mm-hmm.
everything was fine. She doesn't have any
Mm-hmm.
problem yet.
Yeah, that's why I got confused. What means after scan, we should tell if it is comes fibroid. Then
Yes,
that's why
yes,
I have
same.
asked you in the starting if there's any other slide where USG report is mentioned like that.
Yeah.
So
So USG was not done in exam actually. USG
yeah,
you
yeah.
had to do in exam. So that's why it was a pelvic mass differential. Harshiba, we won't tell differential as a cancer because she otherwise didn't have any features of cancer at all. I mean, the history in exam, she did not have any features of cancer. So you'll tell the differential that this mass can be arising from any place in the lower tummy. However, most probable diagnosis is that it is coming from the muscles of the womb, and this is an innocent growth. We call it as fibroid. So this is how the station has to be taken forward. Okay, so just take your 40 seconds to confirm all these management plan so your applied clinical knowledge goes smooth. All right, it goes smooth. For this applied clinical knowledge reason, the patient safety went borderline as well because the differentials were not told according to the diagram. A correct diagnosis has to be made, probable diagnosis, of course, and then you have to speak this one line. After the ultrasound, we will be confirming that and we'll talk in detail about these management options. Pros and cons of each, as I told you about these management plan, expectant medical, the UAE, the imaging, and the surgical management as well. So if you'll take the pelvic mass outline, students were confused that it was an on-call station or it was a gynae station. Basically, it was a gynae station for this reason that it was a fibroid, but it presented as urinary retention. So introduction, agenda, information gathering. In information gathering, please follow the table. I won't ask you to ask all those questions which I've written on the table, but at least 2 questions to rule out everything, specifically metastasis, specifically pressure symptoms. Explain the most probable diagnosis, the management options, address the concerns, and then it should be a mutually agreed plan. So this is the outline you all are going to follow for the pelvic mass. I'm open to all the questions. If something is not clear, please. Yes, yes, Harshiba. Anything which is not clear, how the question came in exam, how we are going to solve it, everybody, try to follow the diagram thing because that gives you a better understanding to the patient because the patient doesn't know what's inside pelvis, right? So you have to, it's a pelvic mass. So just draw a
Dr.
diagram.
Sidra,
Yes,
I
Mike.
was wondering about the malignancy questions because you said that the size of the mass increased in a short period of time and that
No,
it's
six,
from.
6 months, yeah. 4 months time it was. And then the last 2 months I felt that even if it's bigger with heavy periods. So 6 month history of HMB, that's not a short history, no?
Yeah, but increase in the size, if it's increased over 2 months and it's hard, I mean, that is why I was thinking whether it can be an ovarian mass.
Again, I would say that you have to tell in the differentials everything. But why would ovarian mass come with flooding and
Yeah,
heavy period?
exactly.
Yeah, so
Yeah.
you have to link up. And this was the thing in exam with students. They were like that typical history of heavy periods was there. HMB history was there along with the mass. And mass too, which doesn't associate with loss of appetite or loss of weight. So these were the only things,
Yeah.
right?
Okay. Yeah.
Yeah, definitely yes, Dr. Sujata. We are going to do CBC and ultrasound. CA125 only if it's an ovarian mass. Okay, CA125, my dear, only if it's an ovarian mass. CBC we would
Oh.
do for HMB along with that ultrasound. So after that, we
Oh.
would see that what the things would be. Okay, got that? CA125 not in fibroid, but yes, in an ovarian mass we would do. Agreed.
Okay.
All right. Okay, thank you very much. Any other question, please? Any other question? Abir, is it clear? Yes? Where are the participants? Let me see. Dr. Sarvat, hello, how are you? I hope it's clear you joined a little late in the middle, yeah? Dua, Dr. Atia. I think Dr. Atia enters into the meeting and then she starts doing her tasks. Dr. Atia? Yeah? Okay, I got you. All right, all right. Okay, let's go to the station number 2. And we have got Fozia here. Hello, Fozia.
Hello.
Hi, how are you?
Hi, Dr. Sidra. Yeah, I'm fine. Thank you.
Oh, that's great. How's your health? How about the fingers? Better?
Yeah, it's fine now. Yeah, much better.
Oh, that's really good. Congratulations for your husband's success.
Yeah.
At least a little ease at home. Yeah, I can
Yeah,
understand
yeah.
the study, the environment when husbands are studying, how crucial that is, how stressful that is. Yeah.
Yeah, it
Okay.
is. It is.
Congratulations, my dear. May you
Thank
be
you so
happy.
much. Yeah, thank you.
Okay. Okay. Great. So let's go to the task number 2. And we are going to do in continuity. And I'm sure Fawzia is going to do great. So 2 minutes started, Fawzia, please.
Next one. Hello.
10 minutes started, please.
Okay. Hello. I'm Dr. Fawzia, one of the doctors. Can I see the first page?
First, yes, please.
Yeah. Sorry. Hello. I'm Dr. Fawzia, one of the doctors in the gynae clinic today. May I know your name and age, please?
So, hi, doctor. I'm Mrs. Monica Benet. I'm 37 years.
Okay. And how may I address you?
Yeah, Monica is all right.
Okay. So, Monica, I understand that you're here because you've been having very heavy menstrual cycles and your GP has referred you to us. Is that correct?
Yeah, exactly, doctor.
So, is it okay if I'm going to ask you a few questions and then we'll together discuss about the care plan?
Yeah.
Okay, then. So, can you please tell me about your cycles and what are you
Yeah.
worried about?
Yeah, the problem is, doctor, that it's been around 6 months that I'm feeling that I started having some problem with the periods in terms of they were heavy. And I went to GP twice. He gave me some medications that is going to decrease the flow. One was some painkiller and one was some sort of a capsule he said that I have to take during the periods. I started them like 2 months back. I do take them every cycle. When I take them, yes, I agree that bleeding is a little reduced, but if I skip them in any cycle and just back to again through the same flooding and same heavy periods, so it's not getting me feel better. It's been around 6 months that I'm having heavy periods, doctor.
I'm so sorry to hear all that, Monica. And how do you think that is it affecting the quality of your life?
Definitely, yes. I mean, now I'm really scared of going outside because I feel that during periods I can't manage it.
Mm-hmm. Okay, I'm so sorry to hear. And how about you? How do you feel in yourself? Like, do you have any shortness of breath or doing your daily chores? Do you have any problem in that?
The problem now is that I feel that I have early fatigue. Not
Mm-hmm.
exactly shortness of breath, but I feel that I'm getting tired early.
Okay. And how about your V? Is that all right?
Yeah, no problem with that.
Okay. And how about your bowel habits?
That's okay.
Mm-hmm. And uh, I'm going to ask you, when was your last menstrual period?
That was around 3 weeks back.
Okay. So I'm going to ask you for certain personal questions. Is that all right?
Yeah.
How you're sexually active?
Yes.
Okay. And do you have any bleeding after coitus?
No.
Okay. And any pain or any difficulties during coitus?
And no,
Mm-hmm. And Monica, do you also bleed between your periods?
no, it's regular, but it's
Just
heavy.
okay. And how about are you updated with your cervical screening program?
Yeah, that's all right. I just had it last year. That was okay.
Okay. And no other problem of like discharge from down below?
Nothing.
Okay. And how about you have two children? Were they normal?
Yeah,
Normal.
they were normal births.
Okay. And are you using any contraception at the moment?
We practice condoms.
Okay. And what about your future fertility plans?
I think I would like to have one more kid, but not now, probably a year later.
Okay, that's wonderful. And any other medical illness that you're following your GP with?
I had my diabetes, it was around 3 years back, but it's
Yeah.
absolutely okay. I'm following with my doctor. I'm taking a tablet for that, and it's settled. I mean, my blood reports are always fine.
Okay, that's wonderful to hear. And how about any other drugs that you're taking or any allergies you're aware of?
I'm not. I'm not taking any
Okay,
medication other than this and that too, only in periods.
okay. And any family history that is of concern?
No, doctor.
Okay. And do you smoke
Very occasionally. I mean, I'm not a regular smoker.
and alcohol?
Occasional.
Okay. And what do you do for a living, Monica?
Yeah, I work as a gym instructor.
Hmm. And how's the support generally? How do you feel at home?
Yeah, that's fine. My partner's really supportive.
Great. And how about your weight to height ratio?
Yeah, that's fine. That's 24.
Okay. So, Monica, I do have your reports, which were anything else that you want to tell me,
And
which
that's
is
it. I
bothering you?
just had an ultrasound, doctor. I would
Mm-hmm.
just like to know, is everything all right?
Yeah. So, Monica, I do have the report with me. Let me confirm your age, which is 37 years, and the NHS number, which is 784381. It does says that the blood reports were done, even though your blood count, your blood reports are normal. Still, your hemoglobin, your blood, this thing is on the lower side, and the ultrasound which we did, it shows small growth. Okay, it is a very innocent growth, and which arises from the muscle of the womb. Let me draw it for you. And otherwise, it is a small growth, as I said, hardly more 2 by 2 centimeters, if you can see in this diagram. And the rest, everything is normal.
I mean, is it the reason? I mean, I'm having this problem.
Well, not necessarily, I might say, because generally we do suspect that if it is somewhere inside, if you see over here, if I might draw over here, and then that might be the cause. But generally, the ones which are lying over here on the top, we don't suspect them to be a cause for your bleeding.
Uh-huh.
However, the
Yeah.
bleeding that you're experiencing, Monica, for the last 6 months is
hmm
definitely having an effect on you. As you said, that you are having some fatigue, that your blood levels are falling. Okay. So, so what we would like to do is that we would try to put you on some medications if, uh, okay, to build up your blood counts. Is that all right?
All right. So this, anything to decrease the blood loss?
Yes, and since you're already taking 2 tablets, you said, I would like you to continue with the tablets, tranexamic acid, which you said you're taking.
Mm-hmm.
That will help to decrease the blood flow.
Mm-hmm.
Okay. And with that, we'll be adding another medications to build up your blood counts.
Mm-hmm.
Along with that, as you said, you are we have I can advise you for a coil, which we can put, which we call as Mydina. Have you heard of it before?
No, I've not heard about that. What does it do?
Mm-mm. So basically, it's a plastic coil which we can. It contains a hormone, okay, which we can insert from down below. It stays there for a period of 5 years. Since you're not worried about having children for the next 1 year, you can keep it, and it definitely reduces the amount of your bleeding. Okay, and
So I
uh,
can get pregnant with that.
no, yes, when you want to have a pregnancy, it means that you can just come to the clinic and have it removed.
So how far
Okay,
is it the chances it's going to decrease my fertility aspects?
so Fertility aspects? No, it doesn't. The moment you remove it, the fertility returns. And the good point is that it will be acting locally where it is required to be working. Okay, that is your womb. So this will help you, alleviate any oral medication that you might avoid. Okay.
That's okay. I mean, other than that, do I have any other option, or is it the only option?
So as far as this, you can also have what we call as hormones. Also, you can take pills. Okay. You can take them back to back for 3 months. This will also decrease the amount of bleeding for you. And the periods, since they are regular in itself, that should not be much of a worry. Okay.
Okay, so that hormone's gonna be safe for me?
Yeah, they can be safe for you,
Diabetes.
All right.
but
Okay.
it's controlled.
All right. I get
Okay.
that. Yeah.
Yeah.
So, other than that,
Other than yes, Monica. So other than that, if you think that this is something that you're not looking for, we can also go for what we call as uterine artery embolization. This is a surgical procedure in which we can go for surgery, in which we can inject certain particles and block the arteries, which is supplying your fibroid, this growth.
this
Also,
2 centimeter, you okay. So you want to treat this?
yeah, so we can also go for a surgery, which can keyhole surgery and remove this myoma.
I get that, right, but this was not causing the bleeding, as you said, right?
Yeah.
Okay, right. Okay. So any other plan of surgery do we have, doctor?
Endometrial ablation, but you are planning for child. Endometrial ablation, but you are planning for child.
Yes,
So
doctor.
you
I'm
can,
listening to you. Yes, doctor.
yeah. The other surgery which we can do is basically we can remove the lining of your womb. Okay, but at the moment, since we don't know whether it is thickened or not, we will differ from this. And another thing is that since you're planning for pregnancy in near future, this is something which we generally don't advise for ladies who are planning have a fertility concern.
I get that, right. Okay. So what do you think is best for me, doctor? I'll just go by your advice.
Yes.
Yes,
I'll give it.
generally.
Mute yourself, Dr. Siddhartha, please. Yes, Dr. Fauci.
So yeah, I will be giving you a leaflet. Have a go for it. Everybody is different, but the first line management we generally advise the ladies wear like you is the coil. Okay, I will be giving you certain leaflets. Have a look into it, and if you think this is something that you would go for, please, I will book you an appointment, and we'll be ready to fit you in.
Okay, if I'm ready for the
And
coil, doctor, if I'm ready for the coil, can you do that today for me? Because I just want that the next periods are not heavy. I mean, I just want the
No,
treatment.
okay,
we need it
so
like 2 weeks back.
Dr. Sujata, please mute yourself. I shall be grateful. Yes, Fauziya, go
so
ahead.
yeah, so what we are going to do is, firstly, we need to know that since you had your periods 3 weeks back, we need to exclude pregnancy also, as you were using condoms. Okay, so once that is ruled out, we will actually advise people. Generally, we insert it once you are finished with your period, and it is day 1 of your period or day 6. Okay, once you're fresh over with it.
I get
Yeah, and once we insert it, Monica, let me tell you that you can also have some spotting, and your cycles may be a little bit of irregularity for first few cycles, like 3 to 4 cycles. But definitely, on a long run, this will subside, and your periods will be more manageable.
I get that, right. Thank you very much, doctor. I understand that. I'll get back to you once the periods start, doctor.
Thank you so much.
Thank you very much. Thank you. Thank you very much, Fauziya. What happened in the applied clinical knowledge? Other than that,
Oh,
it was a
sorry.
beautiful station. No problem
Sorry,
at all.
doctor.
No problem. It does happen.
Really, no practice, Dr. Sidra. Really, I don't know what went wrong with me. Yeah.
No, I understand. It was only in the applied clinical knowledge. You were going very good. But when it came to the applied clinical knowledge of Monica Benet, the fibroid is not an issue here. So we have to skip UAE, right? So the management plan was, again, see, I always tell you guys, it's not only for you, please relax, just have a glass of water. The important thing is, Fauziya, that we learn that we are going to make an organized management plan. Okay, When we make an organized management plan and outside the cubicle, we are sure that what is going to be the management plan, you do it as a medical management, as a surgical management, and you speak it like this. So the examiner is sure in medical management, non-hormonal, hormonal. In surgical management, ablation and hysterectomy. So we have nothing to do. Yes, definitely, yes, Dr. Bindu. She has got a beautiful voice. Many plus points are there. Only just in the end, there was a little fumbling, which we are going to improve together, Fozia. Nothing to worry, okay? Right?
Yes, Dr.
So
Yes, Dr. Sidra.
now, yes. So let's go to the positive points. The positive points were, and what was happening with Dr. Sujata? Dr. Sujata was doing the station on her own. I'm happy that she was doing, but she was unmute, you know, in between she was talking and telling the points.
Sorry, I am very sorry. I didn't realize that.
I was so happy that, you know, whatever Fazia was saying, you're trying to get that point, but you were unmute. So it was like double voice in between. So very good that you were getting the points, but it was a little, you know, disturbance to the flow. Thank you very much, Dr. Sujata, for being attentive, my dear. Okay. So this was a station about Monica Benet. I was very happy with the introduction, Fazia, the way you started the station. You were saying that sorry to hear about your complaints, the quality of life. I get tired early. You did ask about my wee, my bowel habits, LMP 3 weeks back, and you did notice that it's patient safety that you're not going to insert Myrina today. So very well done. You did do a signposting of sexually active. I gave you a star on that. You did ask about the pain and the bleeding, intermenstrual bleeding. I gave you a star again when you used the word cervical screening. I just taught you guys in the previous station and you picked it up. Very well done. You did ask about the discharge. You did ask about the obstetric history regarding the normal birth of 2 babies. You did ask about my condom practice, and you did ask about my fertility desire. That was in 1 year time. That was very good. Again, I gave you a star on that. You did notice that I'm having a condition, diabetes, and that's controlled. I was in a casual smoker, occasional alcohol taking, so that was all correct. You did ask about the support and the BMI, so all went fine. All right. So you did confirm my name and age before telling me about the investigations, and you had drawn about the serosal fibroid understanding. That was correct. And you were right in telling me, absolutely right, that had it been submucosal, had it been inside the womb, it would have been the cause of the bleeding. So medications you told me about, then you told about the Mirena as the first line. That was good. You did come to the ablation point, and then it's safety, that for the patients who require fertility, that's not a preferred option. You gave me a PIL, and then about the hormone coil, we came to a mutual agreement that it's going to be done once I have my next period. So all these points were good points. In 2 minutes time, there was something like I'm sorry to hear about your complaints. So that was something like which I appreciate. Other than this, if you have to say the word intercourse or sex, coitus is a little difficult. What we can say is simply that do you have any problem or discomfort during sex or during intercourse? Okay, pause here. We can say that
Yes.
openly. So don't feel a little shaky in speaking this word rather than any problem with coitus. You can say any problem with intercourse, any problem with sex. So that's something which you can easily use during the talk.
Okay.
When I, as a role player, said that I have diabetes, however, I'm having regular checkup with my diabetic doctor, and I'm taking a tablet and it's all controlled. You said how wonderful. So
Oh, sorry.
yeah, no, it's okay. It is good that I am having a control of a condition, but I always suggest avoiding these terminologies. Why? Because at times patient might not be happy. I mean, that I'm having diabetes or something. So
Yeah, sure.
the words
Sure.
wonderful, great,
Yeah.
these gestures at times can put you in difficulty. So
Yes.
I always suggest my students to be smart enough that don't make it a habit of using these words, because at times they can be at an appropriate place, but at times the same words can put you in difficulty as well. So it's better that you say, all right. So all right is a
Yeah.
gesture which is like you have noted, or okay, noted. So thank you for
Yeah, sure.
information. So these words are
Yeah,
fine
noted.
that you want to give a gesture that yes, you are listening to the patient carefully, rather than saying, oh, wonderful. So
Yeah.
at times these can put you in difficulty. So I always avoid my students to use these terminologies because that can put them in difficulty. Okay. Now, regarding the HB, there was a little fumbling about description of the HB. An open question, please. Yeah, am I right, Fazia? Yes.
Yes, yes,
So I
Dr.
got
Sandra,
to
I
remember
forgot completely. I was
blank.
like so nervous. Yeah, I was blank and I didn't know
Oh,
what
no,
to say
no
really. I'm so
problem, my dear.
sorry.
No problem. Nothing to be sorry. This is like, I can understand. See, I know you guys. You people were absolutely silent when I announced the session just 5 days before the session. Believe me, the mini groups were so active. There were 100 messages in both in A, B, C, D. And I was like, wow, I mean, just 5 days before the session, if I be strict with you guys that, this is the session and these are the topics, in the last 5 days, everybody was practicing. So if you people do it like one station every day, believe me, the flow would not be breaking up. The problem is that your flow tends to break up, which should not happen, right? Okay.
Yeah.
So anybody, please, how do we tell about the hemoglobin? How do we tell the patient that it's 10 and that's on the reduced side? Open question with everyone, please. It's been long that I've heard few people. Like,
Iron levels.
yes, please.
Iron levels in your blood are low.
Okay.
I
What does
think.
that mean? Yeah, anything else? Yeah. Hi, Shiva. Okay, Dr. Bindu says the blood levels are low. In the blood levels, Dr. Bindu, it can be WBCs and platelet as well. So, some specific blood levels. Okay. So, I
The
would
red
say,
cell count is
sorry,
low.
yeah.
The red cell levels are low. I mean,
Okay.
it's not actually red cell levels, but yeah. And then we can say that, and this reduces in turn the oxygen carrying.
Thank you. This is what I wanted. Thank you very much, Jyoti. I was waiting for this thing so that you link up with her fatigue. Okay. So what you say is that the blood cells which carry oxygen, they are low, and that is the reason that you are having early fatigability and tiredness. So we are going to give you medication to build up these levels and follow you after 4 weeks with the test again. That's it.
Okay.
All right.
Okay.
So this is
Yeah.
what you're going to say. You have to link it up so that she has an understanding that part of tiredness, lassitude, easy fatigability is being dealt with, right?
Yeah.
Dr.
Yeah.
Bindu, you can say hemoglobin, but after explanation. How? That not first like your hemoglobin level is low. What you're going to say is that the blood cells which carry oxygen, we call them as hemoglobin. They are at the lower side, and we will treat it with certain medications to rise it up, and we'll follow up in the next report. So now you can use hemoglobin because you have explained. So first you're going to say hemoglobin, she would be like, what are you talking about? So you can say after explanation, and then you can use the word hemoglobin. All right, am I clear? So regarding the next thing, the management plan. I know that everyone out of you, 100% knows the management of HMB. There is no ambiguity that heavy menstrual bleed management is not known to you guys. I want you all to be organized. Now, rather than saying that the first line is Myrina, and then we have got an option of drugs as well, I want you all to be very clear in the management plan in terms of please organize yourself. When you come to the last 3 minutes, always organize yourself. Like if I would have been at Fauzia's place, I would have said completely that, yes, Monica, now coming to the plan of management. Now, because of this heavy bleeding, we have got a medical management and a surgical management. No, Liana, cervical screening is an English word. So that is what you say, that cervical smear you used to say. Now you would say about your screening, your cervical screening. So screen, they know that they're being screened according to the pathway. Okay, Liana, got that? So this is what we are going to say to them instead of smear, because now screening in half of the places has been shifted to HPV. All right. Why am I worried about this? And I'm going to do the new algorithms with you guys in the oncology as well, because just in 19th paper, there were like one question regarding the new screening. So that means that the college has shifted to the HPV triage. Okay, Liana? Yeah. So if the college is shifted to the HPV triage, we all should know the new one. Am I clear?
Yeah, we have already shifted to the HPV first.
Yeah, that's very good.
I'm
Few of the
BSc.
centers, they're still doing smear, but maximum have been shifted to the HPV triage. So that's the reason I have asked all my students to rephrase their question rather than saying, may I know about your cervical smear? What you have to say, may I know about your cervical screening? Is it up to date? So screening is going to cover up both. So you will be safe in exam. Am I clear, Liana? Liana, did you get the point of changing this question? Okay, right. Now, coming to the management plan. So, Monica, we have got a management. in terms of medication and the surgical management. In medications, we have got non-hormonal, which you have already taken, the medicine to decrease the blood flow, which is a painkiller, and the tranexamic acid is a capsule which you have taken. These are non-hormonal medicines. We've got hormones as well. And in hormones, the best, according to the evidence, is the hormone coil. Now your explanation would be fine. See, make an outline in your mind so the examiner is clear that you know about the management rather than picking up directly something in the middle. Make your outline and then come to this management plan of Mirena coil, then tell about the hormones. I said, is it safe for me? What I wanted you to say is that we have got hormones with a single hormone and a combined hormone as well. Fawzia, I wanted you to basically tell me about the progesterone, norethistérone, and the combined pills as well. You get my point?
Okay.
So basically in hormones, we've got two varieties as well. A one which contains a single hormone and the ones which have the combined, a combination of two hormones, right? Okay.
Okay.
So then coming to the surgical management, it was only two here, endometrial ablation and the hysterectomy. So that was what you had to touch. And of course, you very correctly said that it does not suit her for the reason that she desires to have a kid. So this is generally done for the patients who have completed their family. So in applied clinical knowledge, I would give you borderline, my dear, patient safety borderline, just for this reason that applied clinical knowledge was a little shaky. Communication with the patient was fine. That was all right. And I was happy with your communication. You've got a good tone, a composed voice, a good flow. At times, a little speedy you are, Fawzia, and I feel a lack of empathy. In the first 2 minutes, please write it down for yourself. Go to the recording of the station, and in the first 2 minutes, there was a statement which you used. I'm sorry to hear about that. Now, I'm sorry to hear about that is a wonderful empathetic statement. We have to say it in empathy. You did say correctly, but you said it in such a speedy manner that like you're fulfilling something which has to be said. Like, it's a task that you have to say. So have some little feel, Fawzia, in that, right? I have written down in the notebook in 2 minutes time, there was a statement said, I'm sorry to hear about that. So it's like, I'm going to say that to you. Monica, I'm sorry to hear about that. So now I go to the question. And the other way I say is, Monica, I'm sorry to hear about that. So what about your next, then I come to the question. So have a little pause in that and don't be very speedy in your empathetic statements because you're saying it correctly. I mean, in terms of speaking those lines correctly at the point, but it's so speedy that it feels that, like it doesn't make that effect. That effect on the patient is not there. I'm sorry to hear about that, Miss Monica. Okay, so just go to that and try to rephrase that so that there's a little feel in that statement of yours. So the impact on the patient that comes directly like the way we want to have. Okay, all right.
Yes.
So let's go to the communication with the patient and relative. Yes, I was happy with your attentive listening. I was really happy with your visual aid. So this is one domain which went really good, 2 by 2, my dear. So the patient safety, you were really right in knowing about the patient's concern regarding fertility. So that was really good. And it was a mutually agreed plan of coming up to the Mirena coil. So that was very good. HMB history, I was happy with. Information gathering was very good and it was fine. One thing which I would like to tell all of you is that she was, what was the age of Monica? 37. Yeah?
Yeah.
So one thing which I would like to tell all of you is because in exam, there can be a heavy menstrual bleed, which is above 40. Whenever it's an above 40, according to the talk article HMB, they say that 40 above, approaching 45, you're going to take tissue sampling from the lining of the womb, right? So the investigation which we mutually agreed that we are going to say that blood complete picture we would send. Yes, Dr. Sujata. Along with that, we would do tissue sampling if she is between 40 to 45. Am I clear? This is as per recommendation. Any sort of a heavy bleeding above 40, we need to do endometrial biopsy. Please note it down. I'm not getting any.
I have a question.
Yes, sure. I'm not getting any message in the chat box. I hope it's working. Please drop in a message so that I can see that my iPhone's working fine. It's connected to Zoom. Yes, please, Jyoti. I'm here. Thank you very much, Liana. Thank you. Yes, sir.
Yeah, I think after 40, we also need to do a hysteroscopy.
It would be hysteroscopy, my dear. it is going to be for intermenstrual bleed and postcoital bleed, local causes. For only HMB, no IMB, no PCB, hysteroscopy would only be for high risk cases. Otherwise, it's only ultrasound and endometrial biopsy. One more thing, in HMB, whenever you have to do a biopsy, as per the
Yeah.
NICE guideline, it would
You have
always
to
be
do
a
a hysteroscopy.
hysteroscopic biopsy.
Yeah, you have to do a hysteroscopy, and you
Why?
need to do a
Because
TBI.
2020 NICE guideline that said that the blind biopsy that is going to be a secondary thing, it's always indicated that you visualize the womb as well. But if it
Exactly.
would be a post-menopausal bleeding, as per the Green Top guideline, it would be a PIPAL which is going to be chosen in terms of the first biopsy. It would be without hysteroscopy. So remember this point. As per the HMB guideline, if you have to take a biopsy, it would be hysteroscopic. As per the post-menopausal bleeding, it would be first PIPAL, and if required, then it would be hysteroscopic. Am I clear, everyone? This is the update in 2020. In 2016, they did not have this update. Okay?
Yeah, but in hysteroscopy, you can do an outpatient hysteroscopy
Outpatient.
while doing the endometrial biopsy, isn't
Correct.
it?
Correct. Outpatient, we are going to do that, and then we are going to sample because the NICE has changed the recommendation. Okay.
Yes,
That was
exactly.
all fine. That was good regarding the template, 2x2 in information gathering. Now, this was the outline which I wanted. Applied clinical knowledge, evidence-based management, medical, non-hormonal, hormonal, explain two in each, and the surgical management. So make an outline always. I want all of you to practice in the same way, please. Once you come to the management, in first 15 seconds, make an outline of the management, then come to what is inside that. That would make your things very organized. It won't be a scattered thing that examiner is trying to search that where you are in your management. You tell the outline and you pick up from the outline inside that what is actually inside those domains of medical and the surgical, right? Now, this algorithm I really like. This is from an Irish guideline HMB. It's not from our COG, but I like it for this reason that they go in a very systematic manner and the recommendations are the same. So all of you, please remember that whenever patient comes for HMB, so you take a history and examination, you go for the full blood count and you do the examination. If she has a fertility desire, you all would go with the non-hormonal medication. In non-hormonal medications, as correctly said, that tranexamic acid and mefenamic, it's going to be in hormonal, it would be combined pills. It can be a pill containing only one hormone. It can be a hormone coil insertion, which is evidence-based as first line. There can be injections as well. So all these are going to be the hormonal, which you're going to explain. If nothing works for her, then it's going to be a surgery. Have you people gone through this patient information leaflet table about the Mirena, tranexamic acid, NSAIDs? I would like you all to please take a printout of these tables, which I'm showing now. The reason is that these treatment plans, these tables, they have some sort of side effects. At times, patient asks you, is it safe for me or does it cause any side effects? So I want you all to learn two side effects of each, okay? One, and this is two for COCP's norethistron, which I wanted to hear because in hormonal norethistron is very commonly used. So patients generally ask about that, injected progestogens. If it's going to be a fibroid, then GnRH. Endometrial ablation side effects, very commonly patient asks for this. There can be a station in which she asks about what can be the side effects of doing this surgical method. UAE only if it's a large fibroid. Remember, don't make it a mistake in HMB. It's not required if it's only HMB without a fibroid. Now, you all have to take a printout of this because this from the patient information leaflet gives you perfect lines how you have to explain. How does it work? Levonorgestrel intrauterine system prevents the lining of the womb from growing quickly. Tranexamic acid helps the blood in the womb to form clots, which reduces the amount of bleeding. Anybody out of you has gone through this? I have already posted that in your study group, the patient information leaflet regarding HMB, and this table is in the end of that PIL. Why do I love this? Because just in 2 sheets, all your HMB gets prepared. So please take a printout and just attach it into your HMB station, okay? So that you all know. You all know what it does. For example, if I say norethistron, okay, this is one hormone. So it prevents the lining of the womb from growing quickly. Okay, so you won't have fumbling in any of this thing. that how does it work. For example, it's endometrial uterine artery embolization or endometrial ablation. See, Fausia, removing the womb lining and it stops bleeding. So this is how you're going to say endometrial ablation. So you won't have problem in explanation of any of the thing out of this. And above all, it starts from the first line and it tells about all the options. The only thing which you have to write is that UAE would be for fibroid, myomectomy would be for fibroid, and GnRH would be for fibroid as well. These three you would say for the fibroid, rest it would be only for HMB. So please see the question. Is it fibroid causing HMB or is it only HMB? So three things you are going to take out from the management plan. It would be if it would be a plain heavy menstrual bleed and not a fibroid. Am I clear, everyone? These two tables you have to take print out and attach in your HMB template. So introduction, agenda, take an information gathering, explain the diagnosis, tell about pros and cons of each, address the concerns, and mutually agreed plan. Okay, so this is how you're going to deal with HMB. Thank you, Fausia. And I'm sure gradually with practice, we'll just improve on fumbling. Okay, thank you very much, my dear. Thank you. All right, so any questions regarding HMB? Thank you. HMB questions, please. Anything which is not clear?
Yeah, one question, Dr. Sidra.
Sure, Jyoti, please.
So you said that if she desires fertility, then we should be giving only tranexamic acid and mefenamic acid. But if she says like she desires fertility, but not right now, maybe 5 years later, so we can still give her hormonal, isn't it?
Definitely, yes, definitely. Even as I said as a role player, Jyoti, that I want to plan a baby, but probably after 1 year. So 1 year is a safe time that you can insert marine. That's okay.
Because the return to fertility is immediate. So
immediate, yes. But if I say that, yes, doctor, I'm just planning a pregnancy right now. So don't give hormone then, because that would be against the patient's safety that she desires fertility and you're giving her a contraception.
Yeah, definitely.
All right, good. Any other question, please? Exactly. Dr. Bindu, we can give combined pills. Absolutely, we can give POPs, but the first line would stay Marina. We will just touch that point that these are other options in hormone as well. Agreed. Yes, Dr. Bindu. As soon as she decides to plan, we are going to stop that. So that is one concern. Okay. Now, there was one more thing which I said somewhere in the middle about the combined pills and hormone. I said to Fausia that is it safe for me? And Fausia was like, yes, it's safe. Yeah, Fausia, what was in your mind at that point? Yes, Fausia.
About the combined pill, Dr. Sidra?
Yeah, when you said that hormones, I said, okay, doctor, I can take hormones. I mean, is it safe for me?
Yeah.
Did she have any morbidity?
Yeah, the diabetes, yeah.
Yeah. So what happens is that, see, it's not a contraindication. But yes, it happens that once you are having the comorbidities like hypertension and diabetes, the local is preferred. So you say that few of the conditions like raised blood pressure and raised sugar levels, we tend to prefer other methods. It can be used, but if other methods, they're not suitable. So this is what I wanted to hear. Okay. All right.
Yeah, because I thought she has just, she's controlled well. If she wants, she can go for anything.
But see, in comparison, I'm telling you, in comparison, you can use, you're absolutely right. But we would say that if other methods, they don't suit or you are not comfortable with the other methods, then we can definitely choose this method. So this would be your patient safety.
Yeah, and that's one of the reasons I think it was at the back of my mind that I cannot give her COCs. And that's why I jumped directly to Myrina.
Yeah.
Okay.
So
thank you so much, Dr.
No problem. These are tiny points, my dear, but that, that tends to polish us that how we have to approach and how we have to be safe in the patient safety domain of the situation. Okay. All right.
Yeah. Thank you so much.
Thank you very much. Thank you, my dear. Okay, so let's go to the station number 3, and the station number 3 is by Dr. Sujata. Hello, Dr. Sujata. This is the time that you have to unmute yourself.
I'm unmuted.
How are you?
I'm fine.
That's really good to know. So, all right. So let's begin with Dr. Sujata. Dr. Sujata, how is the station going to be? What is the station we are going to do?
PMS.
Okay, you want PMS.
I don't know.
It's not PMS. I'll have PMS,
Okay.
but after few stations. So
Okay.
let's see, what do I have now as a role player. So 2 minutes they start, friends, and this is Dr. Sujata's station. Yes, please.
Next slide.
I've changed that.
Yeah. Next slide. Can I have the first slide, please? The first slide. Yeah. Shall I start?
Start, please.
Hello, I'm Dr. Sujata, one of the doctors in the clinic today. Can I confirm your name and age,
Yes, sir.
please?
Hi, doctor. Doctor, I'm Anne Morton. I'm 20 years.
How do I call you?
Anne, you can call me.
Oh, okay, and what do you do?
Oh, yeah, I study. I am living in a hostel, just preparing for my annual exams.
Okay, and from your notes, I see that you had some pain 2 weeks back, and some tests were done, and you've come for the follow-up. Is that right?
Exactly. I was having some tummy pain. I came here and they took some tests. They wanted me to get admitted because I was having severe pain. But actually, this is a very sensitive time of my study. I just have my exams and I had been paying a lot for these exams. I had been putting in so much of effort. I cannot leave this time. I have to appear after 1 week time, doctor.
Oh, and I'm very sorry to hear about that your exams are around. Yeah, but how are you doing now? The pain and all, is
Yeah,
it
the pain.
better?
Yeah, I'm taking the painkiller, and after painkiller, I'm fine. I mean, there's a slight discomfort which I can manage. I mean, I can have a control over that.
Okay, so before we discuss your reports, can I ask a few questions, please?
Mm-hmm. Yeah.
Yeah, this before this 2 weeks, did you ever have pain before like this?
No, it was like first time, and it was a little severe that I had to come here because I did take painkillers, but it did not relieve. So I had to come here. I had an ultrasound at that time. I had an examination at that time, and they said that it's going
Okay.
to be some sort of a swelling they can feel, but I had to rush back to my hostel because my friends they were studying.
Okay, okay. Now, this can you tell me more about the pain, Anne?
That pain at that time.
Yeah.
Yeah, that was very severe. That was like something is like crushing inside. Something is like being twisted inside.
Okay. Was there any vomiting along with it?
I was feeling sickness. Yeah.
Okay. And do you feel any sensation of heaviness down below in your tummy?
Not down below, but I feel in the tummy that
Mm,
there's a little heaviness, but I can cope with that, doctor.
okay. And does it affect your peeing or your bowel movements?
No,
Okay. And how are your cycles as such? Your menstrual cycles?
no problem with cycles.
When was your last period?
2 weeks back.
Uh, um, and can I ask a few personal questions, if you don't
Mm-hmm.
mind?
No, that's okay.
Are you are you sexually active?
I'm not doctor.
I Do you have any partner? No.
No, no, I'm not sexually active.
No, you cannot. Not sexually active. Okay. So otherwise, okay. Then otherwise, do you have any other illness for which you are taking medication with
I'm
the GP?
absolutely healthy.
Okay. Did you have any surgeries before?
No.
Okay. Do you have any known allergies? And
No,
what about your height for weight ratio?
that's okay. That's 22.
Okay. And do you smoke? And
I'm just with friends. I mean, I'm not a regular smoker.
what about taking alcohol?
No, doctor.
Okay. And any street drugs for fun?
No.
Okay. So, is there any family history of concern that you'd like to tell me?
Not exactly. Everything is all right, though I visit my parents a little with a gap, like it's been around 1 month's time. But I live in
Okay.
hostel. But yes, everything in family is fine. I mean, nothing in which I would like to tell you significant.
Okay. So, and your family is supportive and
They are.
okay. So now I would like to examine you, if you do not mind, in
Mm-hmm.
the presence of a chaperone.
Okay.
I would like to feel your tummy and see how the mass is.
Mm-hmm. That's okay. Okay, so I'm
It's
here
in
to know
front
about
of
the
me.
ultrasound. Yeah, doctor,
Yeah,
please tell me. I'm a
I
little
have your
in
report.
a hurry because,
Yeah,
see, my friends are waiting, and I've told you that this is a very precious time for me.
yeah, and I can see that. I will quickly go through your reports. I have
Mm-hmm.
confirmed that it belongs to you with your age and NHS number, and it says that you have a mass arising from your ovary. I can draw it for you. This is the uterus, and you have two ovaries on either side. I hope you can understand that, Anne.
Mm-hmm.
And on your right side, there's a large fluid filled cyst, and it is 16 centimeters. Okay. And they've done a blood test also to see whether it is significant, this large cyst. And it has come out that it is little on the higher side. It is 200. So, are you with me, Anne? So you have
I
a
get
cyst.
that. What does it
Yeah.
mean?
It means that it's not good for that cyst to remain inside. It will be good if it is removed.
Uh,
Are you understand?
no. I mean,
Yeah, you
remove
have to
when?
do as, yeah, it will be good if it is removed as soon as possible, because 2 weeks back you came with pain, because these cysts can either burst or it can twist on itself, or it can bleed inside when it's
No,
of a large size.
what are you talking about, doctor? I've got my paper just the first exam starting after 7 days time. I mean, I had
I
been putting in so much of finances, so much of effort, and these are the annuals. I mean, you're not understanding this thing. I don't have pain. I mean, how can you say that, please? Ugh,
Yeah, I understand your concern, and we are here to support you. And definitely, I can give you sick leave so that you can take your exam in the next sitting. But this has to be addressed before, because otherwise, it will be difficult for you, and because you might again get severe pain, and then if it's either twisted or if it's burst, then it will be very dangerous for your life. So
ugh,
I would advise you, don't worry. We are here to support you, and don't, yeah. Would you like to take that glass of water and drink and calm
thank
down?
you.
And
Thank you, doctor. But how would it happen? I mean, how many days in the hospital? What's going to be the procedure?
Yeah, because this is a large size, and we will have to do through a cut on your tummy, and you will be in the hospital for at least 2 days. And if everything is fine, then you will be sent home. So after that, after 1 week, you will be able to get back to your normal activity, depending on how you go through the surgery.
My God, all the plans, they're shattered, doctor.
And I can see that you're really distraught. Don't worry. Your health is more important, and we are here to support you. And definitely, whatever help you need from us in the form of sick leave will be given to you. So do not worry. I think you should share this with your parents so that they can support you in the surgery which you should be having. And I would like to book an appointment with my consultant so that once you decide about it, I'll give you the information leaflet as well so that you can go through the type of masses that can arise from the ovary so that you will have an idea. Okay, Anne?
I get that, doctor. I'm really disturbed. I need a little time to decide.
Yeah, I know that. I know I've given you a lot of information and a lot of concerning news for you. And some, and I since that we'll have to do one more test just to make sure everything is fine inside because it's a large mass and your CA125 is on the higher side. So we'll be referring you to a team of doctors so that they can decide after this special investigation called the MRI. Have you heard of it?
Yeah, I've
No?
heard of that.
Yeah, so I would like to give you an appointment for the MRI, and with that, you can go to the specialized team of doctors and they will decide on the type of surgery to be done for you. Is
That's
that
okay,
right?
doctor. Give me a little time. I'll get back to you.
Yeah, sure. I hope you're a little reassured now that we are here with you, and do not worry about your exams. We are here to support you.
Mm.
Okay, Anne?
Thank you very much, doctor. Thank you.
Thank you.
Right. How was it, Dr. Sujata? Anne gave you a tough time, yeah? All right. How was the station? Yes,
Station is a
friends. How did
known,
Dr. Sujata do?
known station, but could have done well.
No, 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 that was a good station. I mean, you managed, and she was very hyper, but you managed to settle her, so that was the good point. Yeah. Okay, very well done.
Okay.
Dr. Bindu is very happy. Fawzia is very happy. Nadra has a thumbs up for you. All right. So,
Okay.
anything where you would like to have done better, or if you are given a second
Yeah.
chance, you would try to improve that point?
Mm, maybe the history taking should have been better.
Mm-hmm. All right. Dr.
And
Sujata, my,
it's,
my suggestion for you is that by nature, by
uh,
a habit, you are a slow speaker in terms of like
yeah,
communication. You are a peaceful speaker, I would say, that you don't rush through the things. So that is
yeah,
like you're a calm person, basically. So, in terms
yes,
of history taking, in terms of starting the station, a little quick, I would like you to be just because of
yeah,
time management, okay?
yes,
Because see,
yes,
everybody has a habit. Like when I talk
yeah.
to Ramya, I always tell her that
I
please
know
slow
that.
down. Yeah,
I
I
know
tell her
that. I
slow
know.
down. So you
Mm,
by nature is a like a calm or a
slow.
composed or a type of a person who is like peaceful in speaking. So when it comes to time
Okay.
management, a little quick, I would like you to be like when
Sure.
once you start the introduction, you're like, hi,
Fast,
I'm
fast.
Dr. Sujata, one of the doctors. So I would like you to be a
Yeah,
little
yeah.
quick. Why? Because we are fighting against time.
Yes,
Okay,
yes, I
so a little
understood.
quick,
Yeah,
my dear. That would be my overall suggestion for you. In
yeah.
terms of good points, the introduction was good. You did register in the beginning that Anne is worried about the studies. You made a good agenda. You were sorry
Mm,
about what she's passing through. You acknowledged that yes, exams are important. You took history taking of twist and torsion, a sickness, pain, how she's coping with that, her problem with the urinary, the waterworks and the bowel. You did ask about the LMP, her periods, She was not sexually active. You registered that. BMI 22, smoking, alcohol, the surgical history. You did examine her. So then you did draw that how is the cyst, and that explanation was fine about the twisting and bursting. That was okay. You did tell about the MDT and telling about the MRI and telling about that she should go with the surgery. So all these points were the good points in terms of management plan. And the best point in the patient safety was providing her with the sick note and writing to school. So all these points were really good. This was a difficult station in exam, not in terms of management. It was difficult because the role player was very hyper. The students, they were telling me that I'm the role player. She was not giving us a chance. Like, she was like, please tell me quickly. I mean, I don't have time. And she was not ready to listen to for even 10 minutes time. So you had to make her calm because she's like 20 years, a little hyper role player. A role player was type of a person who is just thinking about studies and not about the health.
Yeah.
So you have to
Yes.
just take care of that aspect during the exam as well.
Yes.
There was little in points to improve. There was a little fumbling in when I said that I'm not sexually active, and then you discussed about the contraception as well. So once patient is not
Okay.
sexually active, it's okay that you
No
don't discuss
contraception.
contraception.
Yeah.
Okay, yeah.
Yeah.
So then there was a little yeah, you did give the sick note. I'll just try to rephrase those lines for a better impact. I'll tell you that how I'm
Yeah.
going to give that. And
Yeah.
then again, tell me, just for this cyst, everyone please. Now I have made you that I have given you that outline of how to do the management plan for any sort of a thing. I mean, I give you the outline. Just following
Yeah.
that outline, what can be the management plan for Anne? Forget what is for her. I have to train you guys because everybody is making a mistake in the management plan. What is the outline of the management plan for an ovarian cyst, please?
I would ask for the characterization of the cyst because it is CA125 is raised, and then we also know because she is young, I think we need to do all the for borderline ovarian tumors, and we also need to do LDH and alpha fetoprotein and
What I would say, what I would say is that with the specialized imaging, we'll also send some other blood investigations to see the nature of the cyst.
Okay.
Okay, this is one
we
thing.
need to do other tumor
So we
markers.
have to do under 40 years, as per the Green Top guideline, we will do LDH, the alpha fetoprotein, and the beta human
HCG.
chorionic gonadotrophin.
Yeah.
Okay,
Yeah.
these three things have to be done under 40 years. That's number one. Other than that, as per the outline, what would you people say? As I give, for example, as for fibroid, I taught you guys that you will go as the medical and the surgical. In medical, hormonal,
Yeah.
non-hormonal. So how would you go about this, please?
Here there is no, because of the size, we cannot manage medically. So we'll have to do surgical treatment.
Do we have any medical management for cyst, by the way, for the GTG?
No.
No. What management do we have?
Conservative management.
I want
we can
exactly. Thank you very much, Liana. Thank you, Harshaba. I want you all to learn this thing that whatever is required for that case, please don't jump to that.
Okay.
Don't jump to that. That is known as dictating the patient. What you all have, thank you very much. If I would have been at your place, I would say that we've got certain options. The choice of the treatment, it depends upon the symptoms, the appearance of the cyst, the size of the cyst, and of course, the result of the blood tests as well. Now, the treatment options for these cases are that we wait and watch. That is, we follow up with ultrasound. And the other is removal of the cyst, either through the keyhole surgery or through the open surgery. And then it is sent for the laboratory study. If you take special case in terms of the ultrasound result, the cyst is larger in size, so it's unlikely that we decide for the wait and watch because the twist can turn around itself or even can burst inside the tummy and can put us in a difficult situation in an emergency surgery. Therefore, the surgical method would be advisable considering your symptoms and your cyst in the ultrasound appearance. However, it would be difficult for the keyhole surgery because there's a chance of bursting and spillage inside the tummy. So it would be advisable for the open surgery in your case. Did you people understand? What did I do?
Yeah.
I said everything. And this is a mistake. This is the third station, and you all are making this mistake. When it was Fawzia, she said IUS directly.
She's absolutely right in telling IUS directly. But when you make a management plan, please tell as a whole and then tell what suits her. I mean, my patient safety when I told the management plan was absolutely correct. I said the same, which Dr. Sujata told that laparotomy would be advisable. But I took the story from wait and watch and then telling her why it would be less likely to be selected in her condition. Am I able to give you idea about why you people make a mistake in the management plan? Because you people are in habit in your clinics telling about what she is having the best in terms of suiting her best. Yeah. So you people forget
Yes.
that your applied clinical knowledge should be giving her options and telling her what suits her best. Am I
Okay.
clear, please? The way
Yes,
I made the
yes.
management plan, did you people see the difference between me and Dr. Sujata's management plan, all of you? Yeah. This is how you
Definitely.
impress the examiner. This is how you tell
Yeah.
her that we know that these are the options. Out of this, why this option suits her best. I would be saying the same as Dr. Sujata said, would just like to rephrase a little for your better impression towards the examiner. If I
Okay.
would have been at Dr. Sujata's place, I would have said the same. And I can see that you're upset and worried about the studies. However, it depends upon the nature of this swelling lump, that how it grows and causes discomfort to you. We shall take care of your routine and keeping your health as the priority and safety. We are going to write to your school as well, and we'll provide you with the sick note as well so that you can deal with the situation with ease and comfort. Would that be okay? Do you want any other support in this regard? We are here to support you as a team. Clear, everyone? Yeah?
Yes.
So now you're
Yes.
going to tell her that for us, your health is priority, but at the same time, we understand your situation as well. So just cram it up. You can write down in your notes, and this is going to make your things easy. So communication with the patient was good, Dr. Sujata. I'm happy with your visual aid and clear, organized explanation about the patient safety as well. The torsion thing, that was really good. Now, again, HOPI, I've written lots of questions here. You can pick up one because it's a swelling. So you can pick up one with the pain, the lump, the pressure symptoms, and the meds to rule out the cancer, and about the examination as well. So just one thing which I would like to do is a little breaking bad news. Just in a way that I can see, Anne, you're here alone today. I have a difficult news to discuss with you. This would make her response a little slower in exam. So do just one line breaking bad news, please. Okay. Do not give her false reassurance that wait and watch would be a perfect way for her, because she is giving you this pressure that I want to just do with the expectant management. So do involve the patient in the process, and it should be a mutually agreed plan. I was happy with her convincing power, Dr. Sujata's convincing power, because I was convinced with this thing when she said that we are going to give you in written about the medical note or the sick note thing, right? So I was comfortable about that. So explanation of ultrasound and blood test, please. That was all right. Do send the next blood test as well, and the specialized imaging to see the nature of this cyst. So that is something which you have to do. The treatment options, wait and watch, and the removal either through the keyhole surgery or the open surgery, and tell about the benefits and the disadvantages of each. This is how you're going to take it along. Introduction agenda, information gathering. Because she was very upset from the beginning, do a little signposting that I have some difficult news to discuss with you. Can I proceed? So that would make a little absorption would be a little more from the and side, rather than just spotly telling her that this is something which has happened and we have to go with the surgery. So go a little slow so that she absorbs it, and then you move forward. The management plan, addressing the concerns, mutually agreed plan it was. And then if she goes home today, so tell her about the red flag signs, Dr. Sujata. So as she said that I'll get back to you with this. So you say that if you have sudden
Okay.
pain, sudden tummy pain, or if you think that you
Yeah.
have got some fainting episode, or that the heart is sinking, or you feel sick or have vomiting, please see us without any delay. Okay, so that would be your
Yeah.
patient safety, that with such a huge cyst, if she's going back, she
Yeah.
should be knowing that what are the red flag signs, she needs to come in
Sure.
emergency. Okay,
Okay.
so that
Yeah.
was all the points about the large cyst outline. These all gynae stations were different stations from the past exam in 2019 November. And if they are the repeat stations, I want that you all are master in solving these sorts of a station in exam. Am I clear, please?
Yeah.
All of you. Thank you very much, Dr. Sujata, for a wonderful attempt. whenever you're practicing in the mini group, a little quick tone. Keep a
Sure.
clock in front of you, a little quick tone I want. Okay?
Sure.
All right. Thank you
Okay.
very much, Dr. Siddhartha. Thank
Dr.
you.
Okay.
Sidra,
Okay.
Yes, please, Jyoti. Yes, my dear.
I have another question.
Sure,
So,
please. All yes.
why are we going to MRI straight away? Hasn't the
We should,
characterization, the aorta classification should have been done on TVS itself?
yeah. So
And we
what you
should
have to
have
say
that
is that the
information.
team of doctors might decide for a specialized imaging. As per the
Yeah,
guideline,
later
CT
on.
scan is for postmenopausal women. And in if after ultrasound, the aorta says that if after ultrasound, if you are
Yeah,
not able to pick the B and
yeah,
the M mode, then
agreed.
specialized imaging should be done. So what you say in exam is that the team of doctors will decide if at all the specialized imaging, and after the blood test results, if it's required, about knowing about the appearance of the nature of the cyst, so that we can take a decision accordingly. So
Yeah,
this is
that's
a
good.
diplomatic station. This is
But from the TVS itself, I wouldn't be happy knowing only the size of the cyst. I would
exactly,
know more
exactly.
about the cyst
Yeah.
from TVS
That's
itself.
that's what I said, that the choice of treatment would depend upon your symptoms and appearance of the cyst, the size, and of course the result of the blood test. So this combination would make us know that what we have to do regarding the management plan. Right?
Exactly.
So this
And
was
also,
inadequate.
why is she still in school at 20 years? She would be in university.
So
Yeah,
yeah,
so we need
this
to
is the
write
question.
another
What she's doing in education, Dr. Sujata didn't ask. Neither in exam, I think you have time to know. But what she knows is that yes, I'm completing my finals. So that's it.
What did
So
she say? She's completing her?
she said in exam that I just
Finance.
have my annual exams.
Yeah.
Okay, she would
What
be
type of exams
junior.
were there? What type of exams were there? She didn't go into that detail. Neither you have to go into that detail because a lot has to be discussed. Only
Okay.
she's worried about her,
Yeah,
Studies.
yeah, that was
study.
just a
Yeah,
casual question.
yeah.
That's
Okay.
fine.
So
Thank
any
you.
other question, please, all of you? Claire, Dr. Bindu, Harshipa, Diana. Where is group A? Dr. Atya, Abir, Dr. Sabia is with patients. Sarvat, Dr. Rahma is not here. Okay, all right. So let's go to the, thank you very much. Abir has a question. Abir is here. Okay, Abir said that I'm here, doctor. All right. So station number 4, who is my friend? Where's my notebook? So it's gonna be Harshiba here. Hello, Harshiba.
Hello, how are
How
you?
are you? Yes, I'm fine. How about you? So
Okay.
what a wonderful practice in the mini group in last 3-4 days, Harshiba. I had 150 messages one day in the group, and I was like, oh my God, had it been earlier, you people just wait for the last 4 days and then you people are sleepless, yeah?
That's true. We actually wait
Okay.
for the last days.
Yeah. So now you're not going to wait for the last days, huh? Make it earlier so that the flow is better. Okay.
Yeah, we really need to buck up.
Yeah, that is must now. You know, anytime if they're going to announce, so that would be really a stressful time. So it's better that we just decrease the stress and utilize this time. Okay.
Yeah, the stress is coming.
Okay, so let's start with the 2 minutes time and let's begin.
Next slide, please. Okay. Next slide, please.
Yes.
Okay, can I start?
Okay.
Hello, I'm Dr. Harshaba, one of the doctors in the clinic today. May I confirm your name and age, please?
Before telling me about this, whatever is happening outside, I would like to tell you, doctor, that it's been around 30 minutes that I was waiting outside. I mean, this is what you generally do with your patients. I had my appointment, just 30 minutes has passed, and I'm asking everybody that what would be my turn. So what's going on today? Everybody is just talking outside that we have to wait for a whole day for the clinic.
I'm so sorry for the delay, Ella. The clinic is running late today due to some unforeseeable circumstances, and we've raised this issue to the management, and they're looking into it. We'll ensure that this doesn't happen in future.
That's
I'm
okay,
really
doctor.
sorry.
Thank you.
Okay, so it's fine if I call you Ella.
That's okay.
Okay, so Ella, I understand from your GP letter that you have been experiencing some problematic symptoms related to your periods. Am I right?
And not related to periods, just before periods, doctor. I've got some mood swings. I'm not into my senses. I just start throwing things here and there. And I actually have mood problems before the periods. As soon as the periods they start, I get better.
I understand your concern. Uh, uh, have you been maintaining a diary which the GP provide by the GP
Yes, it's
regarding
been,
your
yeah,
symptoms?
yeah, it's been around 6 months that all these problems they started. In the first 2 months, GP asked me to maintain a diary. I did maintain that diary. I have shown that to GP as well, and he started me with the combined pills, which is not working at all.
Okay, I'm so sorry to hear that, Ella. According to your the combined pills, it's been 4 months since you've been taking it.
It's been last 2 months, but I stopped it in just this cycle. I didn't take it at all because it's not having any benefit to my symptoms.
All right, Ella, may I know if you're aware of the components of that pill that you are taking?
Not exactly. He said that this is what we give in this PMS thing.
Okay, I understand. Any other problems besides the mood swings that you're experiencing? Are you feeling low or depressed anytime?
It's just that I'm angry. It's just that I'm loud. I mean, my partner is really sick of my behavior. My boss is ready to kick me out of the job because in those 10-15 days, doctor, I know I'm doing wrong, but it's not like which I'm doing. It's out of my control. So it's
Yeah.
just happening that I'm loud. I'm just angry. I'm just having mood swings. I'm hyper. That's it.
I can understand you must be going through a terrible time. This knowing that things are not in your control. We are here as a team of doctors to help you, Ella. We will discuss all your complaints and all your problems and come up with a management plan for you. But I'm going to ask you a few questions about yourself before that. Is that okay?
Yeah.
Ella, can you tell me more about your periods?
Periods are regular. They're always after 1 month, and they're on the spot on the same date. Yeah.
Mm-hmm. Okay, when was your last period?
The period was around 1 week back.
All right. Have you been up to date with your cervical screening?
Yeah, that's fine. I had one.
Okay. And I can see from your notes that you have one child.
Yes.
Can you tell me more about the delivery?
I had two pregnancies, doctor. My first child, he was born through a cesarean section. He's 3 years. After that, I had an unwanted pregnancy. There was some condom rupture. And I
Okay.
had this unwanted pregnancy. So I planned with my partner's mutual agreement. We planned for the termination of pregnancy. It was ending up. And they planned some suction in the
Okay.
hospital and the pregnancy was over. After that, I asked them to give some permanent method so that I do not
Mm-hmm.
get pregnant for the next 3 years. So they placed a rod in my arm. So
Mm-hmm.
currently, I'm just having that. I don't know what did they do in that ending up of procedure. I never had a problem since my beginning age of 12, 13 years in my periods, before periods, the
Mm-hmm.
most symptoms. But just after that ending up of pregnancy, I have these severe symptoms, doctor. So I just don't understand that what did the doctors do in that
Okay, I'm going to note all this down, Ella. Do you have any plans of having children in the future?
after 2 to 3 years.
All right. Any other chronic illnesses running that you've been visiting your GP for, or any other medications you're on?
Nothing like that.
Okay. Any
I've
allergies to
just
any drug?
taken I told you that only combined pills, that's it.
Right. Any other allergies to any drugs?
No.
Okay. Any surgeries performed on your tummy or down below?
Just cesarean section, doctor.
Right. Do you have any previous problems with clots in your legs, or any problems with migraine, or any
Mm-hmm.
a history of jaundice in the past?
Jaundices?
Experiencing yellowing of your skin or your eyes?
Nothing like that, no.
Okay. Any history of clots in your family or cancer
No,
in your family?
no, doctor.
Okay. Also, one more question. Is there any history of any previous episode of depression in you or your family?
And nothing like that.
Okay. So what do you do for a living?
Uh, for I'm actually an engineer, and I work in an engineering setup, but now the things are not fine there.
Yeah, I can understand that it's affecting your work life as well. Do you smoke or drink or use any recreational drugs?
I used to do that, only smoking and alcohol, but the GP asked me to stop that, so I did that. In the last 3 months, I've really reduced it to maximum.
Okay, that's a very good thing to hear, Ella. How are things at home besides your mood swings? How's the support at home?
Otherwise, we were a happy family. It's just like because of me, I understand that now for the last 6 months, things are not going fine.
Okay. Also, I would like to ask you a few private questions. Is that okay?
Mm-hmm. Yeah.
Are you currently sexually active?
Yes.
Any problems, pain or difficulty during sex or after sex?
No.
Okay. May I know your weight to height ratio, Ella?
22.
Okay. Okay, I've asked you what I needed to know. Is there anything else that you would like to add, please?
Oh, that's it. Please tell me some solution to it, or else I'm really, really worried, doctor.
Okay. So Ella, I can see that you have been maintaining a symptom diary, and your GP seems to agree with the diagnosis of premenstrual syndrome. Have you ever
Mm.
heard of this?
I'm totally aware of what it is. I've read a lot
Mm-hmm.
about it in the last few months. I just want that something to be started which actually improves my symptoms.
Yes. So Ella, I would like to inform you that since you have been given this implant in your arm to for contraception, it contains a hormone called progesterone, and usually this hormone does lead to symptoms like mood swings and bloating and similar symptoms like what you are experiencing. So maybe this is one of the causes why it has been aggravated since the past few years that you are on it. All right.
Mm-hmm.
So what we can do is we can plan removal of this implant in your arm, which is going to be a small procedure, and it's going to take very little time, and we can hope some improvement in your symptoms after that.
Okay. All right.
Okay, so Ella, as you already know, this syndrome is related with a lot of psychological and physical symptoms, like the mood swings you're experiencing, feeling a pain in your breast or pain in your tummy or bloating.
Mm-hmm.
And it usually comes 2 weeks before the onset of your period, and gradually disappears by the end of your period. It's related with some hormonal changes that are present in your body, with your eggs being released from your ovary, and that hormone is progesterone. As I've already told you, as the progesterone goes away, your symptoms also go away. So this is what you've been experiencing so far, Ella. There is a management plan for you. I would like to elaborate on it. First of all, it's a very good thing that you quit smoking. It's going to help you with your symptoms. Also, since you are keeping a symptom diary, I would advise you to continue maintaining it for another 2 to 3 months to see if the symptom that the management that we plan for you is working. Okay.
Mm-hmm. Mm-hmm.
So there are a few things that we can do. First is some simple lifestyle modifications that you can incorporate. Then there is a medication therapy, which the medication can be hormonal or non-hormonal.
Mm-hmm.
As I can see, you already taking some hormones. I will elaborate on that on it. And last management is management of last resort, in which if nothing else works, we'll have to go for it. Okay. So the lifestyle modification, basically you have to try to lose some weight. You need to get a healthy balanced diet and do some exercise or meditation, try to reduce stress. All right.
Okay.
In the medications, the since you've already been started on hormonal medications, I would like to know if you're taking it only in the past, only for 2 weeks before your period, or throughout your cycle.
That was continuous.
Okay. Ella, I would like to suggest you a certain medication which is known as the combined oral contraceptive. It comes with progesterone called drospirenone, which is one of the better ones to reduce your symptoms. So, this is one medication that you can take. You can take it continuously without any break. Also, in other hormonal medications, we have estrogen patches or estrogen creams that can be given along with the progesterone support, so that the increase in the womb lining does not take place, which usually happens with estrogen. Okay. Besides this, there are non-hormonal treatments like antidepressants. We use these antidepressants not for the purpose of antidepressants, but because they help with your symptoms. All right, are you with me?
Yeah, I am. Wind up. Yeah.
Okay. Yeah, I would like to also tell you that if nothing like this works, then the last resort is the removal of your womb along with your ovaries and tubes. Um, I will write a prescription for you, giving you the oral contraceptive pill containing drospirenone, which you have to take continuously. I'll write it to your GP, and I'll also provide you with some patient information leaflet that you can go through. If you have any problems, you can always come back to me.
Thank you very much, doctor.
Okay, thank you for your time.
Thank you. What was it? Only the
Went
time.
overboard.
Yeah, that was a long
Yeah,
station. Sorry for
yeah.
being a bad role player, but that was actually the meat of the of the station. So, how
Okay,
did you
yeah.
feel doing the station? Anywhere you were stuck up?
Yeah, I think I was not very organized with my plan.
Uh-huh. It goes for Harshita. It goes for everyone out there, please. Ella Watson, severe mood symptoms, only mood symptoms. Other than that, no other issue. Do you people agree with the prescription today she got? All of you, please. Open
I
question for
forgot.
everyone.
I forgot the talking therapy.
Yeah, and that's fine. That was not the ultimate. That was something which you had to do. But as per the guideline, as per the recommendation, you have to treat the PMS according to the symptoms which are bothering, right? Yeah.
Mm,
So
yeah.
basically, she should have had her SSRI started today,
Mm,
because combined pills, they are generally best for the physical symptoms.
okay. Mm,
You did mention in the beginning, Harshapa, that yes, the rod is one of the reason, but do remove it today, yeah. So in the end, yeah. So we are going to remove the rod today, and along with that, provide her with some contraception as well. Like COCPs need to be continued. Why?
yeah.
Because they're going to give that benefit of contraception along with that PMS thing, and start SSRIs. So this would have
Okay.
been the ideal management plan for her in the end. Though you did mention all 1, 2, 3, 4 as per the algorithm, but ideal for her was starting SSRIs. Okay. So
Okay.
I'll guide you. There were certain very good points, of course, as per communication, as per settling me. Uh, I would suggest all of you that maybe one of the station would be in which there's a delay in the clinic. So never let the role player get angry. Don't give such opportunity to the role player to get angry. Always tell in the very beginning. For instance, if I would have been at Harshiba's place, reading that 30 minutes, the clinic is late today, I would not go starting with the name and the age. I would say that, yes, hi, this is Dr. Harshiba, one of the doctors in the gynae clinic today. At the very outset, I would like to apologize that because of some unavoidable circumstances, the clinic is running late today. I would like to apologize. We are already looking into the matter, and we are sorry for the inconvenience. So something in the beginning so that she doesn't get upset, right? Then you can come to this. May I confirm your name and age? So start the story after apology, or else she would get really angry. Don't give her opportunity to waste your time. Right? Okay, no problem, Harsha. But that's why what I say, that whenever something is written there, that's written for purpose. Why would they write that clinic is 30 minutes late today? So you're expecting some response from the role player. I'll give you one example. I was in the Tingam, and there was a station in which it was written that the role player is searching for the car parking for the last 2 hours. And I was like, why have they given it in the candidate instruction? I mean, what can I do if the role player was searching for the parking in the last 2 hours? It was like when I entered into the cubicle, role player was like so angry, and I was not able to take the history. Then I had to apologize. I had to ask that this is the reason, sorry for inconvenience. The management is looking into this. I can connect you to pals so that you can launch your complaint, so that we can settle this issue as early as possible. So do you people get the point? That is for your, that feel that you understand that outside the cubicle, what can you expect inside? All right. So be ready for that and try to cover it up so that your time doesn't get wasted. Now, you did apologize, and then you said that unavoidable reasons they were there. That was very good. You did ask about the information gathering diary, about the combined pills taking, about the benefits it's having. You did say that I can see that it must be very terrible for you. That was very good. About the support, you did ask about that. That was very good. And about the menstrual cycle history, it was 1 week back. You did ask about the cervical screening, all about termination of pregnancy. You did note down allergy, surgical history, the clot, the medical history. You were right in explaining jaundice. You do that in the same way, right? Yellowness of the eyes and the skin. So any problem with the liver. So this is how you can associate that. Quality of life, support, BMI, all these were asked. You came to this point that yes, implant can be one of the reasons. The role player directly gave you this indication that she doesn't want the explanation of PMS. Please come to the management. So you were right in picking it up. Now she knows about the PMS. Then the medical, then you came to the management plan. Again, I would like a little more organized management plan in terms of the outline. Okay, I'll come to this. Now let's see the points to improve together. Harshiba, did you confirm my age? Name you just did by the doing that. May I call you Ella? But you didn't do that.
Yeah. I did.
So once you apologize, I would do that again. See, hi, I'm Dr. Harshiba, one of the doctors in the gynae clinic today. At the very outset, I would like to apologize that the clinic is late today due to some unavoidable circumstances. Sorry for inconvenience. We are looking into the matter so that it doesn't happen again. May I confirm your name and age, please? Yeah? So now your station begins. So that thing didn't come. I mean, age wasn't there. I have written on the points to improve that I did not confirm my age at all. So this is patient safety, right? So if something has happened, why did this happen, Harshiba? Because the way you are in habit of entering into the cubicle, things they didn't go that way. So I immediately had disorganized your entry, and I said that, what do you mean, doctor? So once you have settled that query, come back to the starting. Okay, come back to the starting. Okay. This is Ella Watson and 28 years. Okay, so then another thing I've written is the jaundice jargon, so that was fine. Around 9 minutes and 30 seconds, when you came to the management plan, immediately you started again like that, Harshiba, that we have to do the lifestyle modification in some management plan in terms of that you have already started quitting smoking. It was your 9 minutes and 30 seconds of the station. Again, if you have to target the scorecard, all of you please listen to me very carefully. The things which I'm going to say here is going to help you guys in getting directly to the scorecard. See, if you start your first line and Harshiba explains that for 1 minute, if she explains that for 1 minute, that this is the first line management and she is not able to touch second, third, fourth, she would not be able to pass. Why? Because the time is up. So you say in the beginning that we have stepwise sequential management for this condition. We have hormonal medications and non-hormonal medications with lifestyle modification in step number 1. In step number 2, we can increase the dose of the medication and can provide certain other hormonal medications as well. If it doesn't work, we go to some injections. In step number 3, if it doesn't work, anything doesn't work for the patient, in the end, we have a final resort of removal of the womb, which definitely would not be considered in your case, Ella. So coming back to step number 1. What did I do? I just took 15 seconds, hardly, friends. Hardly 15 seconds. But what am I telling to the examiner? I know the algorithm of PEMS. What you guys do is that you pick up first and you start explaining that, and the time is over. Am I able to tell you guys that where do we need to become crisp in terms of the applied clinical knowledge? Now I would come back to number 1. Now whatever happens, I'm not worried because my block of applied clinical knowledge is ticked because the examiner has come to know 1, 2, 3, 4. I have read the green top guide. Now, if it coming back to 1, now I start explaining because I was noting down. I was waiting that Harshaba touches 1, 2, 3, 4. And at 9 minutes and 30 seconds, she said, now you've done a good job that you're already cutting down on your smoke. So that's number 1, meditation, yoga, and all these things she started explaining. So please see in terms of examiner, what do I want? In terms of examiner, the first step has been ticked, but she started explaining that. So actually 9 minutes, 30 seconds were there. I was waiting that, I was eager to give her score for applied clinical knowledge. Am I able to make you guys understand? Please give me input so that I can understand that the thing which I'm going to inculcate in you guys in the management plan, you people are getting that, please. Because now, if the scorecard is not touched, no matter we speak 2 minutes for conservative management first line, 3 minutes for that, or just 5 seconds for that, we have to catch the scorecard, please. Okay, we have to catch the scorecard. Now I'll come to step number 1 and tell her the prescription of all. Now I will tell about the yoga, the exercise, the lifestyle modification and all. Okay, because now I'm safe. 1, 2, 3, 4 has been touched, and immediately mentioning hysterectomy, I immediately said that see that it is something which we are not going to consider in your case. So coming back to the first line of management, Ella. Now I'm safe. So the first step is that we are going to remove this rod in the arm today so that the management is effective for you. And we'll provide you with the combined pills. We'll suggest that you continue combined pills so that it has an effect of contraception, along with that, the effect of treatment of your condition as well. Do you people understand the point? That how I'm going to come back? Now I have got around time to spend on my first line of management. Please be safe in your station. Students, they know everything. The only thing is that they're not able to do that in a smart manner. Okay, right? Now, coming to the communication with the patient and relatives. Harshaba is one of the students whom I'm always comfortable with her communication. She has a grip over the language. She has a composed voice. So I'm always happy with her handling. I mean, even when I made her shaky, that, doctor, what do you think? I mean, this is what you guys do in the clinic, that the patients, they're waiting outside. So she was able to handle. So this is your strong point, Harshaba. I'm always happy with your communication with the patients. Avoid jargons, okay? And just work on this. This is your strength. Okay, this is your strength. Believe me, as a mentor, I feel that this is your strength, that you can communicate in a good manner. And I would like to polish you more as the exam would be approaching, of course, because this is something which we need to, if something is your strength, of course, we need to use it for scoring higher. And I'm sure you'll do that. History taking was 2 by 2. I was happy with the history taking. Information gathering undoubtedly was 2 by 2. She did ask about the medical conditions as well, asthma, epilepsy, migraine. So that was very good. So all these points were well done. Best thing was that she did understand that it was a progesterone causing. It happened in exam. This was my exam station. It came many times, 3-4 times. You'll see in your PDF. At times, the role player says I'm taking a pill, the single hormone pill. At times, the role player says that I'm taking the hormone. I have the hormone rod in the arm. So this was a good thing. Though I wanted her to remove that in the end as well before I leave the clinic, but she did mention somewhere inside that means that she picked it up. So that was very good in patient safety. I didn't get time to tell about the complementary therapies. But in exam, the problem was that the role player, in the end, you tell her about all the management plan, and in the end she says, the doctor, my friend, she told me that something like Vitex agonist is really having a great benefit on these symptoms, so I want to take Vitex agonist. Harshiba, what would be your answer, please?
It We have to tell the patient that although
Mhm.
it's there's not much.
Harshiba,
Okay.
because time was
Okay.
over, so I couldn't do that. Now I'm saying as a role player, doctor, my friend is really having a great response to Vitex agonist. I would like to take that, doctor.
It is helpful in certain women, but in women who have episodes of low mood and depression, it might aggravate them. So, I would advise you to use it with caution if you decide to use it, although evidence is not sufficient for Vitex agonists.
Okay, so where in the world did you read that it can worsen the mood symptoms, Harshiba? Or it just came to your mind just now and you made it up, yeah?
No, no, I read it somewhere. I don't
Okay,
know.
I'll tell
I
you, no
read it
problem.
somewhere.
I'll tell you, relax, relax. Okay. Now, see, two types of responses came from the students. Dr. Sabiha, few of the students, they were like, sorry, we don't know about that. We'll read about that and get back to you. And few of the students were, sorry, what are you asking about? And the bell rang, okay? And few of the students were like, yeah, that's one of the complementary therapies which generally is used. I would like to suggest to you that whenever it's taken, traditional trademark, uh, that should be seen so that you know that it's safe. Remember that when it comes to the complementary therapies, in complementary therapies, something like is known as a labeling of THR, traditional herbal registration. So please note it down. In 2-3 types of stations, the patient comes to this in HRT, hormone replacement therapy, in PMS, they tend to ask some sort of a complementary therapy role. So what you have to say is that, Harshiba, when you have to start your sentence, always acknowledge and always respect. Whenever patient asks for something which is not evidence based, please do not deny or do not from the beginning say, no, it will not affect. This, I want every student of mine to note this thing, that you're not going to say that no, it does not have any effect, or no, it would not be beneficial for you. Okay, all these things have to be avoided. How would you start? Please write down in your notebooks. If role player is asking for some complementary therapy, the first sentence would be how you're going to communicate. Start the answer would be, she was Ella, right? Ella, I respect your desire and concern to take Vitex agonist. However, unlike conventional medicines, it is no legal obligation for the herbal medicines to be licensed and in actual content. If you buy any herbal product, always look for the product license or the traditional herbal registration number. It is advisable to buy these from the reputable source. I would like to make a suggestion that we continue with these medications. Along with that, you can take it sidewise because the evidence suggests that taking it alone might not benefit you in the same way as these medications they do. Do you have any further concerns? So
Dr.
now
Sidra,
I'm
can you please
patient free.
repeat? Unlike legal medication, it is not necessary that it. I missed that.
Yeah, it is not necessary that it has the actual content or it is licensed.
Okay.
If you buy it, it should have THR, traditional herbal registration number, to ensure that it is checked for safety and quality. And you buy it from a reputable source. It's not that you're picking up herbal medication from anywhere. So this is the answer to the herbal remedies. One patient can ask you in the circuit, maybe something like related to HRT at times, or it can be related to PMS as well. So this is something you should be knowing about the Vitex agonist. If you go to 2018 May, there's a picture of Vitex agonist in your PDFs as well. You people can open it up. Some Some student has given the copy paste of the detail of Vitex agonist, so you people can see that there. Okay,
I
so
read it from there about this depression.
okay, all right. So you just have to say start it from respect and concern. Okay, and say that alone it won't be beneficial, but yes, you can take that with these medications if at all you want to. But alone, it might not have the same effects as that of the medication. Okay, so this was about the patient safety. Investigations, you did the diary, that was good. And we didn't require GNRH because already diary diagnosis was confirmed. Lifestyle modification, medical, surgical, and the complementary therapies. This is how the algorithm goes. So you're going to say that we have got, again, I'm going to repeat that I'm going to complete that in 20-second time. First line, second line, third line, fourth line, and please come back to first line. Exercise, along with that, talking therapy. How do we say about CBT? A talking therapy under specialized doctor who is going to make your mood symptoms better. The combined pills, and along with that, listen to me, Harshaba, very carefully. We are going to start special medications which release happy chemicals in your blood and improve your mood symptoms. I did not use the word antidepressants. Yeah? Medications which release happy chemicals in your blood and improve on your mood symptoms. We are going to start that in a lower dose and see how it works. We can increase the dose in your follow-up plan as well. We have certain other hormones in the form of patches, and we can give the hormone coil for the support for the progesterone hormone as well. That's it. Your management is done because you've already discussed the third and the fourth line in your first go, which you need not discuss today. So only discussion would be on talking therapy, and that it would take not more than 2 minutes time. Not more than 2 minutes time to cover all this. Okay, so you just need to confirm that she understands about the SSRI and you start the talking therapy and the SSRI in a lower dose today. So the medications which release happy chemical, which improve your mood symptoms. Up till now in exam, only mood symptoms came, but you should be knowing that the patient can have some breast pain as well. So some sort of a migraine as well, or you can give the first, second, third, fourth line in the same way. But if she asks specifically of the primrose oil, why did I put it here? Because the Green Top guideline says that yes, primrose oil is effective for the breast pain. Isoflavone is effective for the migraine. That is all can be given for the breast symptoms as well. So this is in the GTG. If at all she asks you, you say that yes, we have got little evidence that these can be beneficial. However, the first step of the management plan is this. So all these blocks are here. I have to clarify one thing to you guys because in EMQs, extended match questions, I get lots of tags on this. Do you people have this understanding what this first line means? Or you people think that exercise is first line. If it doesn't work, then it's CBT, then vitamin B6, then pills, and then SSRI. You should be knowing that everything in block 1 is first line. Okay? Everything in block 1 is first line. It's not that COCPs are preferred to SSRIs. It is according to the presentation of symptoms that either you choose COCPs or SSRIs. So COCPs are for the physical symptoms. SSRIs is for the mood symptoms. Both are first line. It's not that you give SSRIs only if you have tried COCPs and they fail. Am I clear about this aspect? Because this is very important. In my part 2 students, they keep on putting a tag on this, but ma'am, you're not understanding this point. Why are we choosing SSRI when the patient has mood symptoms and COCP has not been chosen? So as per the strategy direction as well, they clearly say that SSRI is first line for the mood symptoms, COCPs is first line for the physical symptoms. Okay, so have this understanding. This first block does not mean that exercise is first. This means that everything according to the situation we can choose, all is first line. This all is second line. This all is third line, and this is fourth line. Am I clear? Yeah? So for the outline, it's introduction, agenda, information gathering, explaining diagnosis, stepwise management, address the concerns. We have got PIL, support group, NAPS is the support group for the PMS. And this is how you do this station. This is a very, very important station. In 4 days of exam, 1 day, PMS is always essential. In the last many years, PMS always comes in 1 day for your exam station. No. You didn't take 9 minutes in history, my dear. I said that at 9 minutes, you were coming to this point of management. At 9 minutes, you were doing the management, and you said that smoking, as you have already reduced on smoking, so that's a good thing. From here, we are going to start the management. So what I was saying was, before that, you did the explanation of the PMS and all. What I wanted was that at 9 minutes, you started explaining the conservative management. I wanted you to give the outline so that you are safe. Okay?
Actually, yeah, I started explaining into conservative because I felt
Exactly.
like if I say conservative medical and surgical, it is just going to be too much for the role player to take. So that is why I started like explaining it first.
Yeah, so you can mention that what it includes is, then we have got, this is the first line, then the second, the third. So we have sequential step of management in these conditions.
Yeah,
This
okay.
tells you that, okay, this is, you're talking about the algorithm. Okay?
Yeah.
All right,
Yeah, got
very
it.
well done. So other than applied clinical knowledge, Harshaba, communication with the patient 2x2, information gathering 2x2, patient safety 2x2, applied clinical knowledge, I will give you borderline, just not going and giving her SSRI today. Okay? All right. Okay. Thank you very much, my dear. Thank you. All right. So well done. Station number 4 by Harshaba. Can we begin with the station number 5? Whose turn is this?
Dr. Sidra, one doubt, like when she says that the GP has explained everything, do we have to explain again about PMS?
No, that is the clue in exam. How do you do after the examination and history and examination? That Ella, do you know about PMS, or would you like me to explain about that? So this is how you get the direction. She says, no, I
Sure.
know everything, doctor. So that means that please come up to the management. If she says, please, doctor, tell me what is it. So now you're getting a hint that scorecard contains the explanation point.
Okay.
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 All right. Thank you very much. Thank you. All right, friends. So we have got here for station number 5. We have got Dr. Abir here. Hello, Abir. How are you doing?
Hello, doctor.
How are you?
Fine, alhamdulillah.
Speak a little more, Abir. Want to check the mic?
Hello?
Oh, yes, that's fine. That's fine. Okay. So station number 5, and the 2 minutes, they start now. Go ahead.
Next page, please. Hello?
I've changed the slide, Abir.
Yes, actually, there is a little bit delay.
No problem.
Okay. Okay, doctor. Hello?
Can you start?
Yes, doctor, I'm ready.
Start, please.
Hello, I'm Dr. Abir. I'm one of the ST5 in Gynae Clinic today. May I confirm your name and age, please?
Yeah, hi, Doctor. Doctor, I'm Gracie Jones. I'm 19 years.
How can I call you?
Gracie's all right?
Uh, Gracie, what I understand from your GP letter that you are bothered by vaginal discharge, and they done for you a test, and you are today to explain the result of your test. I am right?
Yeah, exactly, Doctor. Yeah.
Okay. Gracie, to know more about your condition, to formulate management plan for you, may I ask you a few questions to know more about your condition?
That's okay.
Okay, and in any point, don't feel hesitate to ask me. Okay.
Yeah.
Can you tell me when you start this charge?
It's been around 3 months, Doctor, that I started having vaginal discharge. I went to GP. He said that it's some sort of a fungal infection. He gave me some tubes,
Mm,
but it didn't work on me.
yeah.
So now I've stopped using that tubes.
Is there any itching?
At times, yes, it's something like yellowish gray in color,
Uh,
and the smell is really bad, which makes me really uncomfortable.
I can understand. Is there any soreness?
If I itch a lot, then otherwise
Uh,
no.
okay. Is there any complaint when you have? First, I think I want to ask if you are actually active.
Yes, I'm sexually active, and I just wanted to discuss something with you, doctor. Can I?
Yes, please.
I just changed my partner around 6 months back, and just 3 months back, I started having this. So I'm really worried that did I get it from my partner?
I can understand your concern, but really, this, according to your history and the report of coming from your GP, it is not sexually shared infection. I will come to explain this with you if you don't mind after complete my question.
That's okay.
Okay. If there is any problem with your water work,
No,
bowel habits,
no,
okay. Have you ever been pregnant before?
no pregnancy, doctor.
Okay. Any concern about using contraception?
We do practice condoms, but not very frequent.
Okay. Any surgery from down below?
No,
Any medical history?
no, doctor.
And I want to ask if you have any drug allergy.
No, doctor.
Okay. Any family history of concern you want to ask? You want to tell me?
Come again, doctor.
Any family history of concern?
No, doctor.
Okay. May I ask if you are small?
Yes, 3 to 5 cigarettes a day.
Yes. And any drinking of alcohol?
Yes, I'm in habit of taking alcohol, doctor. Maybe 1 or 2 units in 3 4 days.
Okay. Any use for recreational drugs?
No.
Um, what do you do for living? Great.
Yeah, I'm still studying, doctor.
Uh, okay. What about support at home?
That's fine.
Okay. Uh, just I want to ask you if you start cervical screening or not.
No.
Okay. Thank you for sharing this information with me. Um, Now, in the presence of chaperone, after your permission, can I examine you? I want to examine you from down below for um, effect of this discharge on your necrophome, on the vagina. Also, um, uh, I want to examine your height to weight ratio. Mm, I want to examine blood pressure, pulse rate, temperature.
That's okay.
Thank you. Now I come to address your concern, Grace. First, I think your condition, um, it is called bacterial vaginosis. Do you hear about it before?
No, doctor. What is that?
See, bacterial vaginosis, it is not a sexually shared infection. It is not an infection. Actually, it is due to an imbalance between the bacterial growth in the vagina. The vagina are occupied by two types of bacteria. One of them is a good bacteria. It's called lactobacilli. They maintain the acidity of the vagina to be mildly acidic. The other type, it's bad type, which is called anaerobic. For any reason or another, there is an imbalance between the presence of this bacteria. So the bad bacteria is more than the good one. So you experience this discharge, which is smelly and that's bother you.
Oh,
Uh,
why did it happen? I mean, from where did I get it?
uh, there are many causes for it. A new partner and multiple sexual partner may be the cause. Use of douching of the vagina, using bubble bath, some of the scented soaps may be the cause. Have you happened to use this before?
This discharge?
No. Have you happened to use bubble bath, scented soaps like this?
Oh,
Some detergents?
I get that right. Yeah, yeah, slightly, yes, yeah.
Um, so, according to this, bacterial vaginosis is a common condition, um, and the treatment for it is simple. Um, uh, uh, um, we can try for it metronidazole. It is a material. You can use it as oral tab or vaginal cream. But I advise you to stop alcohol intake um, while taking this material because it may be lead to an effect. It's called disulfiram reaction. That's make you feel sick, nausea, headache. So we advise you to stop alcohol while taking this material.
What if I cannot stop that? I mean, if I cannot stop that. I mean, do I have any other alternate?
Yes, there is another alternate which is called the other is the clindamycin. It can use as a tablet and can use as a cream. Um, uh, you are with me?
I am. I think I cannot stop alcohol, doctor.
So we can prescribe prescribe for you the other option, um, which is which is a clindamycin. But within the clindamycin, if you use it intravaginal, I advise you and recommend to use another thing for contraception because it affects the efficacy of condom. It may lead to break condom and you may face unplanned pregnancy and you are still student and not well prepared yourself for pregnancy.
I get that. Doctor, I was discussing with my best friend about the problem which I'm having. She told me that yogurt is really very helpful in this condition. I mean, she had this situation and yogurt really helped her to improve with her vaginal discharge.
Yes, yes. But till now, there is no good evidence at this moment that yogurts or something called probiotics, that there is no good evidence till now that these preparation are helpful in treating or preventing bacterial vaginosis.
Mm-hmm. Okay, so you think I should not take that?
You can try it. You can try it. But as I say, there is no good evidence to use it.
I get that,
Okay.
doctor. So, what am I going to start today?
I advise you to reduce alcohol. If you want to use the metronidazole,
Mm-hmm.
and also I want to advise you to for full sexual health screening because bacterial vaginosis by itself it's not an infection, but um, it will be increase your susceptibility and make easy for you to catch another sexual transmitted disease if your partner have it. Also, use shower rather bubble bath if you use it, and using soap substitute such as aqueous cream on the genital area. It is already simple measures. You can use it.
Okay, yeah, wind up, Dr. B, yes. Yes, wind up, yeah.
Hello?
Yes, 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 wind up, the bell rings, yeah.
Okay. This is patient information leaflet for you, and thank you for your time.
Thank you very much. How did the communication go with Gracie, 19 years? Yes, Abir, how was it?
Um, I don't know. I forget a lot of things.
No, but patient safety was really good. I mean, the alcohol point, the condom thinning out
Yeah.
point, that was wonderful. That was really good. So I was really happy about that. Okay, so anything that you could have done better? Anything if you do redo a station, you could try to make a change? Yeah.
I think I should explain to her about the report that a glue cell, what is a glue cell.
No, that's okay. Oh, she needs to know about the diagnosis. You did tell that yes, we have confirmed it through the through your screening of the vaginal discharge, and it shows that it is this condition.
Yeah.
So that was perfect. All right. So there were many good points. Your introduction to Gracie, agenda making, your information gathering regarding her discharge, the smell, the itch, the partner history, telling her that it's not an STI, about the waterwork babble, surgical medical history, drug allergy, family history, about the cervical screening has not started yet, that was fine. You did examine, you explained bacterial vaginosis. You told that it's not a sexually transmitted infection. I would like to improve upon the explanation, just to rephrase for your polishing. However, yours was fine as well. Metronidazole, you did tell if at all I am ready to reduce this alcohol, that was okay. Clindamycin, you did tell as an alternate, that was perfect. The STI screening and the information leaflet. Points to improve in smoking and alcohol. When in history I did say that I do smoke, I do take alcohol. Do you remember that you have to connect me to the NHS smoking cessation for patient safety?
Actually, I want to say that, but when she say I smoke just 3 cigarettes per day, I think it is not worthy to mention NHS stopping.
No, 3 cigarettes per day. Is it? Okay, so Abir thinks that you're permitting the patient to take around 3 cigarettes per day. Yeah, you think it's like acceptable. Yeah?
Yeah.
No. Okay, friends, so for 3 cigarettes per day, an open house discussion, please. Is it okay, Dr. Atia? Would you allow the patient to take at least 3? And from 4, you're going to do the smoking cessation? No. I think in the entire session, Dr. Atia, where are you? Dr. Sabiha? All right, I think they are not there. And you people don't listen to the session, yeah? Group A, you people enter, and then I think you go disconnect the audio, and then you listen to the recording. Am I right? Where are you guys? Okay, Dr. Rehma is not there. All right, so group B, C, D. Are you going to
Just
connect her?
finishing the chores before coming and joining the meeting. The domestic chores.
Come again?
Sorry, I said, now Friday only off. The only off in the week. So I have to finish all the house chores also, also finish the studying also finish the class. So
Dr.
everything is going side by side.
Dr. Tia, put the headphones in your ears and do everything, yeah? Just listen to me, okay? Okay, and complete your work. Okay, thank you. Yeah. So yes, not to allow smoking. Very good, Dr. Sabia. Yes. So 3 cigarettes are way too much, Dr. B. Please don't allow her, okay? Connect her to the smoking cessation. All right? Okay. Oh, Dr. Sabia is in an emergency. Dr. Sabia, is it an abruption? Is it a previa? Okay, take care of your patient, all right? Abruption, okay, so just take care of the patient, please. That's important. You can get back on recording, okay? Patient's life is important. Okay, yes, Dr. Sujata, for alcohol as well. You connect to the supporting services for reduction of alcohol, okay? Supporting services, you say, for the reduction of alcohol and counseling, okay? Right. Now, this was about this NHS smoking, which was missed, which I wanted for the patient safety. explanation, I'm going to improve a little. And now coming to this point that when I asked about the yogurt, and I was waiting for the same answer as I told Harshiba. When I said the doctor, my friend, she used yogurt and that was really effective. You said, I've written your answer, Abir. Yes, yes, but we don't have any evidence for this. So how we are going to answer? How would be the start? Abir? I respect your desire and concern Gracie to take yogurt. However,
yes.
Yeah?
I can understand your concern.
Thank you very much. Always respect first and then say no. Please remember this point or else your communication with the patient goes cross. Never give a denial straight away to the patient, please. Okay? And you know, we learned this in IELTS. We learned this when we had to talk to the patient. They always say in your communication, always respect the person. Never say that no. And whenever you have to say that, you always say, you can try this. Always give the positives as well. Because patient has something, you outrightly say no, that is a little embarrassing for the patient. Okay? So yogurt is not something which is bad, right? Yeah? It is not something which is bad. So always appreciate. Now, coming to the points which I would like to rephrase for you guys, please. Bacterial vaginosis. The way Abir explained was understandable as well, but I would like to make it a little easy. The way I tell my students to explain is that, see, Gracie, we have got some friendly bugs in vagina, which makes it healthy. And there are certain times when there is an imbalance in certain situations, like raised sugar levels, they can lead to have an overgrowth of those bugs, and we call this condition as bacterial vaginosis. Am I clear? Am I clear, friends, that how we are going to explain bacterial vaginosis? Yeah? Harshiba noted down, Dr. Sujata, Dr. Bindu? Yeah? Good girls. Now, about the yogurt, I would say, see, taking a yogurt, why would I stop her outrightly, all of you? Yogurt is written in patient information leaflet as well. Yogurt is a probiotic otherwise, okay? So you don't have to stop her from yogurt. This is something nutritional. If I would have been at Abir's place, I would have said that, Gracie, I respect your desire and concern to take yogurt. It has a very good nutritive value and it also increases the strength to fight against the infection. However, taking it alone as a treatment plan might not be successful, but definitely you can take it. It would aid your medicines to work better and treat your condition. Would that be okay? Isn't it a better answer? All of you, please, isn't it a better answer? That it is a probiotic. So how do you say it? You don't say probiotic. It increases the strength to fight against infection. Okay? So you don't have to stop her. But if she says that it's a replacement for metronidazole or clindamycin, yes, she's wrong. It's not a replacement. But yes, she can take it along with that. Definitely, it has a very good nutritive value and it has got its own benefit. So it would aid the treatment to be successful. Am I clear? So note it down. These were my answers when I solved the station. I solved the station because it came in back in 2016 and 17 as well. Then it again came in my exam, and it was it is a much repeated station. So you know, it was around 8 minutes of my stations were done. And I was like saying in my heart, Sidra, yes, yogurt question is coming. Yogurt question is coming. And she was not asking that. Just like last 1 minute, she said, Doctor, can I use yogurt? I was like, yes, I was waiting for this question because I had planned an answer to it. Please ask. And I remember still, that was my 14th station of the circuit. The last station was bacterial vaginosis. And when last minute was there, I was like, oh my God, she has forgotten in instructions. Yogurt is also there. Why is she not asking? And when it was like last 1 minute, she said, Doctor, can I use yogurt? I was like, oh, thanks God, I knew the answer. She asked this question and then I came up with this answer. And I still remember a little smile on my examiner's hand. And I just handed over the small diary, which we had to give back after the 14th station. So I had a sigh of relief. Oh, okay, thank you. So now I knew the answer and she was very happy with this. Yeah. So this is how the station goes. So, you know, certain things, they are repeated. So if they are repeated, you should be master in this. Okay. Why am I giving you my lines? Because this is how I used to plan for myself, that how I can settle the role player at the same time. I have to be safe as well. My students, I always say that you all should outrightly shine in your circuit. because we put in so much of effort in giving the lines and all, which definitely I see the others, they have difficulty in this. So you should stand out, okay, in your communication, in your plan, in your flow. So communication with the patient and relatives was very good. I just improved on this, 2 by 2 in communication with the patient, my dear. Just improved a little on the lines, Abir. You just have to cram it up and speak it up, sweetheart. Okay. Information gathering was again 2 by 2. I've given all the information gathering, which alcohol, don't forget, because metronidazole has an unpleasant reaction with this. Patient safety was very good in terms of alcohol, in terms of the condom may break with cream, getting thinned out. It's not an STD. Very well done, Abir. I was very happy. I would like to improve a little on the applied clinical knowledge in the conservative management things. Abir, lots of things like, the bubble baths and all, we do need to say. So how we put that here is that this is the condition where the friendly bugs in the vagina, which generally makes it healthy. There are times because of imbalance in certain situations like raised sugar levels, they can lead to have an overgrowth of these bugs, and we call it as bacterial vaginosis. So I would suggest, Gracie, that certain lifestyle changes are done. Avoiding soap bubble bath, wearing breathable undergarments. What did I say, guys? Yeah, please listen to me carefully. How do you say that to patient? You say wearing breathable undergarments. In other words, not wearing tight. Okay? You speak it as breathable undergarments and cleaning from front to back. These are all the preventive measures for having recurrent vaginal discharge. In the medical management, we have got a cream, metronidazole as an oral tablet and a clindamycin cream. And this is going to be taken for 7 days, and we are going to follow you up after this. I would just like to make a suggestion here that safe sex practice and the use of condoms are very essential in this condition, not because it's a sexually shared infection, but it increases the chances of other sexually shared infection to occur in the patient. Am I clear? So did you people understand the outline? All of you, that how we are going to do that? Yes, the idea of making algorithms for you guys is that you people have a clear understanding what you need to touch. So applied clinical knowledge was fine as well, but just to be a little more organized and better here. So introduction, agenda, information gathering, explaining the diagnosis, evidence-based management plan, addressing the concerns. It should be a mutually agreed plan. She's happy with metronidazole or she's happy with clindamycin. She can definitely take yogurt along with that, not alone. PIL, and call her for follow-up for the testing if the condition is treated. Am I clear? Any questions regarding bacterial vaginosis, friends? I'm here to answer. Yes, please. Everyone clear? Did you note down the things which I told specifically? Clear? Okay, very well done. Thank you. All right, so we have got station number 6 here, which is Dr. Athiya. Thank you very much, Abir. Very well done, my dear. Keep it up. Keep it up. Hello, Dr. Athiya. Can we have you here for the station?
Hello.
Dr. Athiya, we can't hear you. A little loud voice, please.
Yes, I have connected the headphones. Maybe that's why. Can you listen me?
Yeah,
can you hear me?
Yes, we can listen to you, and we can hear you as well. Okay, so can we start the station? You're ready for that?
Yes, doctor.
Okay. Let's begin. 2 minutes, please.
Next slide.
Yes. Yes, please.
Hello, I'm Dr. Rahman, one of the doctors in the gynae clinic today. May I confirm your name and age, please?
So, hello, doctor. Doctor, I'm Amanda Spencer. I'm 37 years.
Okay, now, Amanda, is it okay to call you Amanda?
That's okay.
Okay, Amanda. I can see from your GP notes that you have been suffering from some pain in the lower tummy and some pain during your periods, and you are here to discuss the management plan. Is it so?
Exactly, yes.
Okay, Amanda. As I'm seeing you for the very first time, so I would like to just ask few questions before we start discussing the management, and together we can make a safe, mutually agreed management plan. How does that sound?
Yeah, that sounds great, doctor.
Thank you. So Amanda, tell me more about your problem. How is the pain? When is the pain coming?
Yeah, the problem is, doctor, that it's been around, I think, 4 to 5 months that I feel that my periods, they're getting very painful. Though I had discomfort from the beginning, but now it's getting more. And the periods, I mean, the days when they pass by, the pain tends to get worsened. I mean, it's not improving with the passage of time in the periods day. I mean, it's less on day one. On day three, I feel it's more. And along with that, it's a lower tummy pain, which I feel other than the periods as well. All the time, I feel that there's some sort of a pain and discomfort in the lower tummy as well.
Okay, Amanda, I'm so sorry that you have been suffering so long. We are here to help you. We will just take care. Have you ever taken anything to cure your pain, like any painkillers, anything
Yeah,
that's
GP.
prescribed by your GP?
Yes, doctor. GP did give me some painkiller, and it was, if I'm not wrong, it was mefenamic acid he gave me. He said that it's going to work for your lower tummy pain.
Mm-hmm. Right. And is there anything that relieves the pain, like for example, passing the stool, opening your bowels, going for peeing, or eating something,
It
or
has nothing to
worsen?
do.
You
No,
already
it has
told.
nothing to do with bowel, doctor. But yes,
Mm-hmm.
it tends to get better maybe when the periods end. So it
Uh-huh.
improves
Right.
when the periods end. Yes,
Okay. Otherwise, how is your bowel habits? How is your peeing habits?
they're fine.
Is
I
it
don't
normal?
see any change in that. Yeah.
Okay. Does this pain interfere with your quality of life and the day-to-day work? Does it interfere in your sexual life too?
Not exactly. It's not that the bowel or the whatever they're affected, but because of this lower tummy pain, I am really worried now because I'm always uncomfortable.
Mm-hmm. Right. And do you feel pain at the time, or are you sexually active?
I am. Yes.
Okay. And how is the things like there is any pain while meeting your partner at the entrance of at the start of the sex, or at the progressive increase while sex, or after the sex, or any bleeding after the sex?
The problem is that yes, when there's a deep sex, I always have pain in the tummy, and that gets worsened. I mean, I feel it for 1 2 hours, and if I take a painkiller, I get better. So sex is really uncomfortable, not in the beginning, but just on the deep sex, I do feel.
Mm-hmm. So how you are coping up with your you and your partner for this?
I take painkillers, doctor.
Mm-hmm. Right. And regarding your bleeding, as you have told me that it's very heavy during the first 2 3 days, and the pain get worse. And other than that, when was your last period?
No, the bleeding is not heavy, doctor. The pain is more after the third and the fourth day. Bleeding is normal as it used to be. My last period
Mm-hmm.
was 3 weeks back.
3 weeks back. And what type of contraception are you using?
Not using any contraception. In fact, for the last 5 years, we're planning a baby and I'm not getting pregnant, doctor.
Okay. And before that, have you ever been pregnant before?
I have one kid, and
Mm-hmm.
that was when I was 25, and that was with a previous partner.
Okay, right. And there was no problem during the birth, anything specific that you would like to
No,
mention?
no,
Nothing. Right. What about your medical, any sort of medical illness that you are suffering from, or anything that you are
no,
taking, any
doctor.
medication?
No,
Okay.
doctor.
Are you allergic to any medication or any
No,
food?
doctor.
Okay. Some like in your family, is there any suffering of like your sister or your mother is suffering from the same illness, having pains long term?
Mm, uh, my sister, she had condition, this endometriosis. She had a removal of the womb, but she's yeah, elder than me. She's like 15 years elder.
Okay, so sorry for her. I hope fully she's fine now.
Yeah, she's better.
Right. And what about any surgeries in the tummy or down below?
For me, no doctor.
Yeah.
No doctor.
Okay. Does your sister had any surgery for her endometriosis?
Removal of the womb, doctor.
Removal of the womb. Okay. Does she have, your sister have babies before that? She completed her family?
Yeah, she's got 3 kids.
Okay, right. And other than that, you have few intruding questions, no? Like, do you smoke?
Doctor, very occasionally.
Okay. Any alcohol?
No,
Okay. Any recreational drugs?
no.
What do you do for your living?
I work as a teacher.
Okay. And how is the support at the home? How do you live?
Yeah, that's fine.
Okay. You live, whom do you live with?
I live in a partner, my kid.
Right. Okay. And in the last 4 weeks, have you ever felt down, depressed, or hopeless, or lost the interest in the things you were interested before?
Just because of this discomfort, I'm a little worried. Otherwise, I'm okay.
Okay, right. Anything, and last thing, are you aware of your height to weight ratio?
22, doctor.
Okay. Anything, thank you very much for all this information. Anything that you would like to add for my information?
I would just like you to tell me that what is the management, what am I having, and how you're going to
Sure.
treat this condition, please. Yeah.
Sure, Amanda. I'm here to answer all your concerns. As you are aware that your sister has been through this called endometriosis. By going through your history and all the pain and the bleeding patterns that you told me, it looks like that you may be suffering from the same sort of a disease. We call it endometriosis. As you heard about endometriosis, I would just like to explain it. See, this is our womb. There is an internal lining of the womb. There is sometimes happening that the internal lining of the womb is deposited or found somewhere else outside the womb, like in your lower part of the tummy, near your ovaries, which makes the eggs, near your bowel, near your bladder. And these all can be one of the reason of having pain. Am I clear?
Okay.
Okay. So once these endometriosis is usually diagnosed on the basis of history, as there is no specific test that can be done for it, other than there can be a keyhole surgery that can be done to do the specific test. What are your wishes for the fertility?
I told you that
As
we
you
are
told
trying to
me,
have a
5 years.
Yes, yes.
Okay. Right. And there are certain treatments that can be offered to you, which can be, as you have already tried the pain relieving medication, which does not help with you. So there are some hormonal treatments and there are some non-hormonal lifestyle changes that can be given, as you're already not smoking, your BMI is under control, but still having a lifestyle changes like healthy exercises and doing some complementary therapies that can be offered to you. But their effectiveness of the complementary therapies, like having reflexology, acupuncture, eating vitamin B1, magnesium sulfate, some of the herbal treatment, there is a limited evidence for their effectiveness. And the other part of the treatment is hormonal, which can be offered to you in the form of pills, injectables, implants, in the form of patches, in the form of some the loops that can be inserted. But most of the hormones are contraceptive. As you're planning for a baby and as you're planning to have a baby, so what I would like to do some of your checkup, like do a complete examination under the presence of a chaperone with your consent to localize any pain where you have any nodule, anything which I can see in your vagina or in your neck of the womb, and may need to run some scans if I could locate anything and any cyst or any endometriotic spots. Even if it is not found on the scan, still the diagnosis will be the same, and we will keep the treatment plan on the same. And we can offer you the other types of non-hormonal contraceptives also, like in the form of progestogens, in the term of tablets. And usually we offer in the first 2 to 3 months the ejections in the form of hormone ejections, which can be given in the implants or nasal spray types also, that can help you reduce your problems for the time being. And you will be kept for a long period for on these tablets and injections.
So would that
So
be
which
safe? I
type
mean,
of
I want to get pregnant, so would that be safe option?
the safe options for you to have will be to go for first to have a scan done, just to locate if there is any cyst, any problem, any endometrioma that can be found. It's a cyst of containing the internal lining of the womb outside in your ovaries and anywhere. And you will be offered usually surgery, like in the form of keyhole surgery, to diagnose and treat at the same time the endometriotic, which are these internal lining of the womb outside, to treat at the same time. It's a small keyhole surgery. Ever heard about it?
Yeah, now wind up, yes.
Okay, so it's like a keyhole surgery that is done, that is made a telescope to go through your tummy and to look inside your lower part of the tummy and to localize any endometriosis that can be found, and that can be removed and treated at the same time. It will be done under general anesthesia, and risk and benefits will be discussed once you decide which type of treatment would you like to go with. Okay, this is an information leaflet that you can read. I will fix another appointment with my consultant. No need to decide now. You can come back after discussion with your partner, and I can fix another appointment with my consultant, and we can proceed with your further management. Thank you for your time.
Thank you very much, doctor. Thank you. How was it? Amanda Spencer, 37 years. Yes, Dr. Athiya.
Yeah, I'm so much like out of practice, so I had to recall myself what history I have to take, what history I have to take.
Yeah, okay. And what about the management plan? Was it an appropriate management plan before the bell rang about a patient who is planning a pregnancy and with endometriosis?
Definitely will go for a laparoscopy, just to make sure
Yes.
that she is having a diagnosis of endometriosis.
Dr. Sujata is writing and she was an express train, yeah, in the chat box. Dr. Sujata, in the end, Dr. Athiya became a train because she had to cover a lot. In between, she was fine with her speed. All right. So, Dr. Athiya, when it comes to the subfertility and the endometriosis, then hormones would be an option, just to tell. But suiting her best would be keyhole surgery and see and treat, which you just told after the 10 minutes bell rang. Okay, so that is the best thing because endometriosis, treating for the patient who doesn't have a fertility desire would be the medications which you mentioned. But when it comes to the fertility desire, then hormones, no, then it's going to be a keyhole surgery, either adhesionolysis or cystectomy, which improves the chances of getting pregnant. So that would be first.
Now the thing is this, actually I got away with that as no scans have been provided up till now, so I am not sure that is she having any cyst or not. And also I got in the flow of the station, I forgot that she's planning for a pregnancy, to be honest.
Yeah, so the complaints of pelvic pain, adhesionolysis even has a better effect on this. Right? So somewhere near the tubes, they say that the conception is better, even if cystectomy, the chocolate cyst is not there. So only that part of the applied clinical knowledge went a little up and down. I was happy with the communication with the patient, offering support somewhere in middle, encouraging her, affecting her quality of life, picking it up. Information gathering was fine, but as you said, that a little delay was there in questions because of probably lack of practice, which now we are going to improve, and patient safety was fine as well. So this was comparatively an easier station as compared to the previous, which we did, because it was a simple station of endometriosis, no complexity, no twist was there. In terms of the good points, your introduction was good. I was happy that you said that as Dr. Rahman. So that was something like a single name, because last time you took two names, I remember. Information gathering was starting with, we are here to help you in this condition. That was good. About the painkillers, about the bowel, asking about the bowel, and making a difference between IBS and endometriosis. That was really good, Dr. Athiya. That showed that, yes, you know, that there's some sort of a correlation between IBS and endometriosis.
This is my routine questions in the OPD.
Really very good. Well done. Very well done. So then it is about the lower tummy pain. Dr. Athiya, in around 4 minutes time, you asked 4 questions regarding sex. So the first thing is always do signposting. You directly asked me that, are you sexually active? So before that, you have to say
Yeah.
that, Amanda, may I ask you personal questions to know more about you? They might sound intrusive. The intrusive question should be here, not before smoking. I know respected Dr. Muhammad way long ago when he used to be active, he used to, guide everybody with this. And I have to take out from all of you, please, this thing that smoking, alcohol, you can ask directly. Don't do signposting before that. But yes, before sexual activity, do a signposting, my dear. Okay, so do signposting before this. And then what did you say? You said like in 4 sentences. May I know that do you have any pain during the sex, any discomfort during the sex, any bleeding after the sex, and how is sex? So the 4 questions are not required. Okay, just one crisp question. Amanda, may I ask you personal questions to know more about you? Are you sexually active at the moment? Any discomfort or pain during the sex? So now if she says yes, and if you need to clarify more, is it on the deep sex or in the beginning? All right. So you were having difficulty in formulating words when it goes inside or something, like you don't have to say, is it on the deep sex or in the beginning? So that superficial dyspareunia and deep dyspareunia, that is ruled out. Okay. And in endometriosis, we all know it is deep dyspareunia, which is actually occurring in the deep sex. So we will just rephrase those questions. Okay. Now, before smoking and alcohol, you said that a few personal questions can I ask? So just skip that sentence, directly ask about the smoking. Then in explanation, there were few jargons, Dr. Athiya, like endometriotic spot. Patient
As I have explained the endometriosis, then as goes in the leaflet also, that once explained the diagnosis, then we can repeat that to just
so
make the thing
endometriosis
shorter.
is fine. Endometriosis is fine. You said that we can find some endometriotic spots. What does that mean? What do you want to say out of this? I mean, what was in your mind when you wanted to say this?
To look for the other endometriotic in the spots, adheolysis, for seeing in the pelvic areas other than the bowel, bladder, and
Okay, so once you explain that, as I said in the previous HB, there was a question. Probably you were busy at that time. Like Dr. Bindu said that, can we use HB? I said first explain it, then definitely you can use HB, because first you have explained one terminology. It is a rule that you can use that terminology further, because now the patient knows about that. You have explained that to her. Endometriosis, as you correctly said, it's a condition where tissue from the lining of the womb is lying outside. So this is something which we are going to see in the examination or in the ultrasound or in the keyhole surgery where we see and treat. So this is now fine. Somewhere in between, I found that you were using the endometriotic spots. I would like to see in the, so this explanation was something like different from endometriosis. So that phrase was a little less understandable as a patient. Otherwise, your explanation for the endometriosis, that was fine. And that was clearly understood that what endometriosis means, where it can be, you were fine in saying. Similarly, you used one word, Dr. Athiya, which was endometrioma. So then you said that, yes, when I said that doctors, you said that, yes, it is a fluid-filled collection when the lining of the womb is inside the ovary. So these words are different from endometriosis. You say when the lining of the womb, it is inside the ovary, it can have a collection of a chocolate filled fluid. We call it as endometrioma if you have to explain endometrioma. So if you don't have to say, you simply have to say in this manner that when the lining of the womb that lies outside the womb, we call it as endometriosis. It can be in the ovary, in the lining of the tummy, elsewhere in different parts of the tummy, in tubes as well. This is fine description of lining of the tummy elsewhere. So these are the endometriotic spots. It can be anywhere in the lower tummy, and as you have done a drawing as well, so that was perfect. That was very good. One thing which I would like to add in medical management is that, see, as we did the other gynecological problems today, if the patient doesn't desire a fertility, you will go with hormones, non-hormones for the painkiller. That's perfect. Whenever subfertility is along with endometriosis, then the evidence suggests please go with the keyhole surgery, because we need to see what's inside. Either we are going to do adhesiolysis, like breaking up the scar tissues, or we are going to see entry if we find any cyst, because the evidence suggests that the conception improves. The chances of getting pregnant, that improves after the surgery for this condition. So I wanted surgery to be at the top after explanation of all the conditions, and then hormones, of course, because if she wants a pregnancy, she's already 37, then your hormone would be secondary, of course, because they would make her have an anovulatory cycle, which we do not want, because we are going to inhibit ovulation ourselves, right? So that would be secondary and surgery would be primary. So only this part in applied clinical knowledge went wrong. Other than that, everything was okay. So information
Doctor,
gathering.
we would directly,
Yes,
sorry
fine.
to interrupt you.
No, no, please.
So this directly we will go for laparoscopy if the fertility is there. We will not going to make a confirmatory diagnosis by giving her the OCPs or by giving her the GnRH analog to make sure that this is endometriosis.
Ultrasound first and then keyhole surgery. OCPs at 37 years with all these symptoms, a family strong history, you will not get.
So, Dr. Sidra, I have a question.
Yes,
if we are getting a similar station in exam and we are explaining, we have asked the history, we are supposed to explain the investigations to her. So, in investigations itself, we will say we will do an ultrasound, and in most cases, we don't find anything on ultrasound. We'll proceed with the laparoscopic surgery, or will we say it in our management plan?
No. Remember that the guideline says that ultrasound, even if it doesn't show this, history-based diagnosis you make before keyhole surgery, because it's an invasive thing. Now for this, keyhole surgery is going to be a secondary thing, but only if she doesn't desire a fertility and you give these COCPs. So 3 months COCP, if it settles, that means that yes, it was endometriosis. However, if the patient has a fertility desire, then keyhole surgery would be a priority as per guideline.
So will we say the management plan for you will include all those conservative medical surgical things in one line, and then explain surgery is the first line
regarding
management
your
for you
condition, as per the fertility desire, regarding your condition, we are going to plan for a keyhole surgery, and in the same sitting would treat if we find out any abnormality in the keyhole surgery, that is see and treat. And we are going to
then we'll say
for the same. Yes, please. Yes, Harshaba.
And then we'll say, after saying keyhole surgery, see and treat, and it should improve your fertility, will we then say that the other methods like hormonal and non-hormonal medications will not be suitable for you because you're looking to
have a pregnancy? Yes.
Yeah. Okay.
Yes. So applied clinical knowledge.
It should be said always in the second line, like
exactly,
first will be
exactly. First would be, this shows to the examiner that you know what is first line for her, right? This is how you have to approach, so that you know that what would be up and what would be like coming down just after this discussion. Okay. So communication with the patient and relative, Dr. Athiya, well done. This is your strength. You always speak good, and a good supporting voice it is, that once the patient requires that, you do support, you do manage the patient well whenever she's in agony. The information gathering was all right about the pain. You did take about that dysmenorrhea and dyspareunia history. You did take about in detail about the cycle detail, and you completed the rest of the template as well. You did examine the patient. Explanation of was the correct diagnosis. You reached to endometriosis. That was perfect. You did give evidence-based management, but I wanted surgery to be earlier. Rest, it was fine. The team of doctors can be there. If we come to this conclusion, basically she had to undergo laparoscopy. So you could tell some possible complications regarding the surgery, that no surgery is devoid of complications. There can be damage to the surrounding structure, bleeding, a stay in the hospital can be a little longer. So 2 or 3 points you can touch about the patient safety. So you should know that we have got a medical management and the surgical management. Regarding the patient fertility desire, the surgical management would be the preferred one, because if we give the hormones for the treatment, they act as a contraception as well. So the pregnancy can be delayed. So this is how you explain, and the examiner knows, okay, this is the reason that you are keeping the keyhole surgery at the top. So this is a safe management plan. Had this patient been of this
procedure of the laparoscopy will be explained fully, right? The procedure, the risk, the pros and cons, and then if the time allows, then go for the medical management.
Then come to the medical management. So this was the applied clinical knowledge which I wanted. Why? Because this was the requirement of the case here, because she desires a fertility. touching medical
In
management.
your template also, you put it on the third line. Why so?
No. This I have given the options. In explaining, I would keep it on the top. I'm telling you that. Why am I telling it like this? Why? Because there can be a station in which endometriosis you have to say that endometriosis you have to tell about the management plan. You would say we have got a medical management, surgical management. However, in your case, we will start with the painkillers and the hormones, provided the same case, but she doesn't have a fertility desire. So you should be knowing, this is a general endometriosis template. You should be knowing that what would be on the top and what would be coming second. I repeat that again. If fertility desire is there, you will not give hormones, because that means you're not understanding that you're giving a contraception. So you will do the surgical management if fertility desire is there. In the same case, if the fertility desire is not there, even then you'll mention surgical, but it would be after medical because it's invasive. Am I clear about the difference between two stations? All
Yes,
of you?
yes.
Very,
Yeah?
very clear. And
Okay.
I totally
Yes,
agree
Jyoti.
with that. The management has to be tailor-made according to the patient.
Patient's presentation
It
and
should
patient's
be,
requirement.
yeah.
Okay, so this
Very
is what you
good.
need to
Thank
remember. Endometriosis can come in a variety of stations. It can come as a chronic pelvic pain, only pain is an issue. Okay, so it can be like giving hormones would
So
be
in this station, we will never going, we will not never, I mean to say, like, we will not going to ask the wishes of the patient, that would she like to go firstly for the surgery, or would she like to try the hormonal treatment which are non-contraceptive.
she doesn't know
It's
that
just
hormones is going to be as a contraceptive, right? So hormone is going to inhibit ovulation. We just, the question which is going to change our management plan would be, are you happy with the family? Is it completed? Or would you like to desire more kids? So if she desires for the pregnancy, your management plan would come up and down. Just 1 and 2 would get changed. The sequence would get changed.
okay. Thank you.
That's it. Thank you very much. So introduction, agenda, information gathering, explain the diagnosis, stepwise management plan according to her concern, according to her desire, address her concerns, and it should be a mutually agreed plan, and then call her for the follow-up whensoever she desires. If you have less time and you cannot explain or complete the laparoscopy, once she agrees to it, then of course, next step would be coming her for the asking her to come for the follow-up, for the consent taking for the keyhole surgery. So this is how endometriosis outline would go. Okay, thank you very much. All right, thank you, Dr. Athiya, for taking out time out of your busy day. I'm really grateful. So now we are done with gynecology. We have got station number 7 and 8 because we had some remaining stations. We will do one from postpartum and one from the urogyne. So I think I've got, let me pause the screen. Dr. Bindu station first. Dr. Bindu? Hello, Dr. Bindu. Postpartum?
Yeah, hello, Dr. Sidra.
Hello, how are you doing?
I'm fine. Thank
Okay,
you.
that's great. So let's start 2 minutes time. A little louder, Dr. Bindu. Please check your mic.
Now.
Again?
Am I clear now?
Oh, that's perfect. This was the voice I
Thank you.
wanted. So 2 minutes, they start now. Go ahead.
Yeah.
Okay. Let's begin.
Yeah. I am Dr. Bindu, one of the candidates for the exam, and I'm ready for the discussion.
All right. So, may I know that what is the definition of postpartum hemorrhage?
Yeah, postpartum hemorrhage is the bleeding of more than 500 ml of blood after normal delivery or more than 1 liter of blood after cesarean section, usually within 24 hours of delivery. Then it is called the primary postpartum hemorrhage. And if it is more than 24 hours of delivery within 6 weeks, it is called secondary postpartum hemorrhage.
So, what are the types of the postpartum hemorrhage?
Yeah, it can be, as I said earlier, it can be primary or secondary hemorrhage. Primary hemorrhage is within the first 24 hours of delivery, and secondary is after 24 hours of delivery. Then it can be mild, moderate, and severe. Like moderate is between more than 1000 to 1500 ml, and severe is more than 1.5 liters to 2 liters of blood. Yeah, and it can be atonic or traumatic. Atonic pph is due to atonicity of the uterus, and traumatic is to the trauma to the genital tract.
What are the causes of postpartum hemorrhage, please?
Yeah, causes can be atonic and traumatic postpartum hemorrhage. Atonic are causes are due to the over-distension of the uterus due to various causes like multigravida, twin pregnancy, and polyhydramnios, or any abnormal masses within the uterus, which is preventing the atonicity, or even with prolonged duration of labor, and that are the causes of atonicity, atonic uterus. And also it can happen with anemia of the uterus, anemia of the patient can also lead to atonic uterus. And traumatic uterus, traumatic pph is due to the trauma to the genital tract. It can be due to the vaginal tears or cervical tears, or it can even cause tears. It can be also due to tears in the uterus, as with a rupture of the uterus, or rupture of the uterus. And usually the causes or hemorrhage are like causes of hemorrhage can be due to the tone tissue trauma. All these things can cause hemorrhage of the postpartum hemorrhage.
How do you manage a minor PPH, please?
Minor PPH, usually I will be calling for, I'll be placing the, I will be assessing the condition of the patient. General survey will be checking the pulse, BP, the respiratory rate, and I'll be arranging a 14 gauge IV line I'll be putting, and I'll at the same time I will take blood for cross matching, and the FBC, and I'll be keeping arranged blood, and if required I will have to do volume replacement of also. And I will be like doing the first line measures, like massaging the uterus, and start her with oxytocin, 40 units oxytocin, 500 ml NS. I'll be starting, and I'll always be also be catheterizing the bladder and keeping it empty, and continuing the massage of the uterus. And if required, I will have to give ergometrin along with oxytocins, and also, or symptometrin, which is oxytocin and ergometrin combination.
And investigations?
Investigations, usually I'll be doing a full blood count, and clotting studies, blood urea, electrolytes, and I'll keeping the cross match 4 units of blood. And initially I'll be if the volume, I'll be checking the vitals, pulse, blood pressure, respiratory rate, and the level of the consciousness. And according to that, I will have to, volume replacement has to be done with normal saline or Hartmann solution, followed by plasma expanders. Like if she goes into severe PPH, then I will have to go arrange for blood and blood products also, depending upon the amount of blood loss.
What is the management of major PPH?
Major PPH, if as I'll be checking the vitals and general survey of the mother which be done, and I'll be checking the abdomen to feel if the uterus is contracted. She'll be kept in a left lateral position and oxygen at 10 to 15 liters of minute, and be assessing the airway. And I'll be putting two 14 gauge IV cannulas and drawing the blood for investigations like foot blood count, clotting study, urea electrolytes, and cross match, and initial volume replacement with normal saline Hartmann solution. And if bleeding is life threatening, I will have to transfuse uncross match O negative blood. I'll be catheterizing the urine and measuring the hourly urine output. And if massage, I'll be doing the massaging the uterus. If still flabby, I'll have to start with oxytocin, syntocinon in 500 ml normal saline given in 2 to 4 hours. Then ergometrin and symptometrin have to be given if she's not controlling. I'll be giving PGF2 alpha prostaglandins 250 micrograms repeated every 15 to 20 minutes for maximum of 8 doses can be given. Misoprostol 800 microgram per rectally can be given. I'll be calling for help. That is, if I initially I have to call for help only, and I'll be calling the anesthetist, the nurse, and my consultant, and I'll be arranging for the porter for the blood, and tell the reception to arrange for the porter and the hematologist. And if the patient is resuscitated and uterus is well contracted, I'll be continuing the same management. If if she's still bleeding, she might be taken to the operation theater where I will have to do a UAE examination under anesthesia to rule out genital trauma. And also the first line, tell the patient, I'll have to debrief the patient before the OT, what all need to be taken to the OT. And I'll be doing she might require uterine balloon tamponade if it's atonicity, and some invasive methods like stepwise devascularization like uterine artery ligation and internal iliac ligation may have to be done. And if B-Lynch procedure of taking brace sutures around the uterus may also have to be conducted. In that case, a laparotomy has to be done. And if if the uterus is contracted, and that is for atonic PPH, if the uterus was contracted and bleeding was still present, I will examine the genitalia, vagina, and cervix for tear and small tear which may require suturing. If the tears are not seen, there is a high suspicion of rupture of the uterus if the patient's condition is also deteriorating. So I'll have to do laparotomy, and if dehiscence is seen, if a rupture of the uterus seen, if it is repairable, I will suture the suture the wound and see if bleeding is stopped. Otherwise, I'll have to even proceed for more radical methods like hysterectomy. And embolization, uterine artery embolization can also be considered if facilities are available at the center.
So what are the clinical governance issues that need to be addressed whenever there's a postpartum hemorrhage?
Yeah, I'll have to first of all raise an incident form and debrief the patient and the partner like after the initial debriefing while going to the OT and doing the procedure, and also gradual debriefing and empathy after the procedure, and I'll to give them all psychological support, and risk management has to be addressed, and we have to consider the future fertility and precautions in next pregnancy has to be addressed.
Okay, anything you would like to add in any of the questions? You've got around 30 seconds.
Okay. Yeah. I think, yeah, it's okay. Done. I'll be also post-operative management of the patient. I'll be shifting her to an HDU or ITU. I'll be considering monitoring the vitals, urine output and bleeding. I'll be putting her on analgesics and antibiotics and proper fluid management and thromboprophylaxis.
Okay, thank you very much. The bell rings?
Yeah, thank you, ma'am, for the time.
Thank you very much. All right. How did the postpartum hemorrhage go, Dr. Bindu?
Okay. Not
okay. So all right. It's been long that you practically read PPH. I'm sure the patients would be there. I mean, PPH is something we encounter almost daily. But in terms of reading the guideline, when did you read the Green Top guideline last time? Just for
Yeah,
my information.
maybe months back, very many months back,
Yeah.
7 months
When
back.
you
Yeah.
said the definition was still 6 weeks, I immediately recognized, oh, it's been long that Dr.
Oh,
Bindu
12
is.
weeks, 12 weeks. Yeah, 12 weeks.
The
Yeah,
definition
12.
changed, yeah?
Yeah, 12 weeks, 12 weeks. Yes,
Thank you
12
very
weeks.
much. Thank you. I'm going to give a sample answer. The primary postpartum hemorrhage is the most common form of the major obstetric hemorrhage, and traditionally the definition states that the loss of 500 ml or more of blood from the genital tract within 24 hours of the birth of the baby. Major can be further subdivided into moderate, that is 1000 to 2000 ml, and severe is more than 2 liters or 2000 ml blood loss. Now, in a woman with low body mass that is less than 60 kg, a lower level of blood loss may be clinically significant, and we take it in the definition of postpartum hemorrhage. The secondary postpartum hemorrhage is defined as abnormal or excessive bleeding from the birth canal between 24 hours and 12 weeks postnatally. Please keep a note. The postpartum hemorrhage is divided into primary and secondary. Secondary is between 24 hours to 12 weeks. However, the primary is the first 24 hours bleeding. We have a minor primary postpartum hemorrhage that is 500 to 1000 ml of bleed, and a major postpartum hemorrhage which is moderate and severe. Moderate is 1000 to 2000 ml. Severe is more than 2000 ml of hemorrhage. According to the Green Top guideline, the causes of postpartum hemorrhage are the 4 T's. That is the tone, abnormalities of the uterine contraction, which can be overdistension of uterus, intraamniotic infection. It can be anatomic distortion of the uterus, use of relaxants, and the bladder distension. The second T is tissue, retained products of conception. Third T is trauma, the genital tract injury. This is the 3 T's. The fourth is the thrombin, which is abnormalities of the coagulation, which can be any bleeding disorders or disseminated intravascular coagulation. When it is a minor PPH, there's a difference between management of minor PPH and major PPH. In minor postpartum hemorrhage, the Green Top guideline says that it is one intravenous access, that is 114 gauge cannula, urgent venipecture for 20 ml of blood for group and screen, full blood count, coagulation screen that includes fibrinogen as well. The pulse, respiratory rate, and the blood pressure recording every 15 minutes, and commencing warmed crystalloid infusion. When it comes to the major postpartum hemorrhage, Dr. Bindu, I'll start with call for help rather than coming back in the later part. Okay. The major obstetric hemorrhage is going to be call for help, senior midwife, obstetrician, and anesthetist, alerting the hematologist, blood transfusion laboratory, and alert consultant obstetrician on call. Airway breathing circulation, oxygen mask of 15 liters, the fluid balance of first 2 liters of isotonic crystalloid and then 1.5 liter of colloid, blood transfusion of Rh negative, blood products, fresh frozen plasma, platelets, cryoprecipitate, and factor 7A, and keeping the patient warm. Side by side, monitoring and investigations would be going. Along with that, the medical treatment would start. To begin with, 14 gauge, but 2 cannulae here, which was single in the minor PPH. Here, 2 cannulae would be passed, 14 gauge size, and full blood count, coagulation, urea electrolyte, and liver function test would also be sent, which were not in the minor PPH management. The cross match of 4 units fresh frozen plasma, the platelets, the cryoprecipitate, that's going to be sent. And along with that, patient would be on ECG oximeter continuous. Foley's catheter would be passed to measure the urine output. The hemoglobin bedside testing would be done, and the blood products should be made available. If at all, the postpartum hemorrhage is not getting settled, there should be consideration for central or arterial lines, commencing the record chart, and weighing all swabs and estimate the blood loss. Sidewise, the medical treatment will begin, which starts from rub-up of uterine fundus, emptying the bladder, starting oxytocin 5 international units slow intravenous, and we can repeat if necessary. Ergometrine 0.5 milligram as a slow IV or intramuscular. Oxytocin infusion as a next step, 40 international unit in 500 ml. Carbopost as the next step as 0.25 milligram intramuscular every 15 minutes up to 8 times, or intramyometral 0.5 milligram. If it doesn't work, misoprostol can be given, and we can consider tranexamic acid 1 gram intravenous. If the medical management doesn't work for the patient and still the patient is having a bleed, we do the surgical management. The first line surgical management is intrauterine balloon tamponade. Before that, it has to be confirmed that it's a uterine atony. Therefore, examination under anesthesia should be done. At this point in time, if there is any clotting abnormality, that should be corrected. If it's a uterine atony and the patient has not got better up till now with all the surgical management, we would start with the brace sutures or the Beeline sutures. There can be consideration to the interventional radiology, stepwise uterine devascularization, bilateral internal iliac ligation, and hysterectomy as the last resort after discussing with the second experienced clinician. In postpartum hemorrhage, as a preventive measure, generally, uterine artery embolization can be done. Specialist radiologist does that prior to, especially it is done in the morbidly adherent placenta or the previa. Post-operatively, patient would be in a high dependency unit or in intensive care unit. I would ensure that the clinical governance is done for my patient, that is clean and clear documentation, a debriefing to settle the couple, the incident report initiating to see the loopholes, the risk management team, skills and drills to have a clean management for the postpartum hemorrhage by the trainees, the nurses, the midwives, and the staff. So this is going to be a complete management plan in terms of the postpartum hemorrhage structured discussion. Any questions? Thank you very much, Dr. Bindu. Almost in all questions, you were clear. There was a little disparity in the distribution of classification and initial definition.
Ma'am, I actually, when I told 6 weeks, in my mind, it came 12 weeks. Then how to correct? Then again,
because I understand, Dr. Bindu. Thank you very much. Otherwise, your medical management was really good, and you knew about the surgical management steps as well. So that was very good. Well done. So this is one structured discussion which comes as a part of labor board as well, and it can come as a separate in a postpartum PPH. PPH doesn't come as a simulated patient task, so you should have a very good a grip over the subject. It comes as the structured discussion. So you should know that what the green top. And Dr. Bindu, somewhere in between, whenever you are saying, just give the reference. So as per the green top guideline. So it gives a very good impression because you're giving a viva to the examiner, right?
Yes,
so when you're talking about anything as per the talk article, as per the green top guideline, this gives an additional score for the examiner. Okay. All right. Thank you very much. Thank you. So here we have, sorry. Jyoti, where are you? Hello, Dr. Jyoti.
Hi, Dr. Sidra, I'm here.
Hello. So last station, I hope you're not tired.
I've been traveling the whole day, but yeah.
Oh, really? I thought you're free today.
I am free, but it was like quarantine, and all that, so not a good frame of mind to do anything.
I can understand.
But
I can totally
I'm out of quarantine.
Okay, vaccination done, Jyoti?
Pardon? Yeah, vaccination has been done, but then there are no rules on vaccination yet.
Yeah.
No government rules on vaccination yet.
Yeah.
So there's still quarantine.
Yeah, I understand. So did you feel any symptoms after the vaccination? How was your response? You had a Pfizer one?
Yeah, I did feel quite a lot of lethargy with the first dose. The second dose was even more, but I was still working. Like I didn't have to take off. Only I got.
Jyoti, were you febrile? Were you febrile after
No,
that?
I wasn't. No.
Okay,
I
right.
wasn't.
So different responses
Just
from different people.
Lethargy and not 100% quite right sort of thing.
I totally understand. Okay, so let's begin with the 2 minutes time, and we are going to do one station from the Urogyne, right?
Sidra, don't give me bladder pain syndrome.
No, I'm not giving you bladder pain syndrome. it's an ST, structured discussion. Bladder pain syndrome is still left. The last station from Urogyne we'll do somewhere in the next. It's a structured discussion, my dear. The charts. Okay, let's begin.
Okay.
Thank you. Start, please.
Yeah, we can start.
Yes, I have changed the slide.
Next slide, please. Is that the first question?
No, that's the only chart. Then questions I'm going to ask. You just have to interpret this chart and make your diagnosis. That's
Sorry to ask you this. Is the name, are the names a little displaced from the line? Like the vesicle is the blue line, and red line is the abdominal, and green line is the detrusor?
Yes, my dear.
Okay. Hi, I'm Jyoti, one of the candidates for the exam today, and I'm ready for the discussion.
All right. So can you please tell me that what do you understand by urodynamics?
Urodynamics is a graphic representation of, it's basically a chart which is made to represent the pressures in the bladder, in the abdomen, and the detrusor muscle. The detrusor muscle cannot be measured directly, so it gets measured by by making a minus from a vesicle minus the abdominal. So it represents also tells us about whether how the pressures of the bladder, the detrusor muscle, and the abdomen are related to each other, and how well the urethra, bladder, and the sphincters hold and release urine. It also gives us an idea of how whether incontinence is either stress urinary incontinence or it is a detrusor overactivity. It differentiates between the two types of incontinence or two types of bladder abnormalities, which is the stress urinary incontinence and the detrusor overactivity. I mean, I would say the urodynamic stress incontinence.
Okay. So can you tell me the diagnosis and can you justify the diagnosis in your patient?
Can I see the chart again, please?
Sure, please.
So according to the chart that I'm seeing, in the first, is it? I think this is the filling phase till the almost the right hand side is only the right hand side is voiding phase, and before that is the filling phase. So in the filling phase, I see that the pressure in the abdomen, the abdominal pressure is increasing while the vesical pressure also increases, and I can see a leak there. So I think this is a stress urinary incontinence or urodynamic stress urinary incontinence. And further down, I see the detrusor. Can I see the chart again?
Yes, please.
So I can see the chart again, and then the detrusor muscle activity is also the detrusor pressure also increases while there is a vesical pressure increase and increase in the abdominal pressure. So I'm not sure what that is. It can be a detrusor overactivity as well, in which case it would be a mixed urinary incontinence.
All right. So can you please
And
tell me that?
symptoms are very much of stress urinary incontinence because she leaks while playing tennis.
So what are the prerequisites for any urodynamic test, please?
So the prerequisites would be before doing a urodynamic test, we should have taken a good history, done a clinical examination, and the predominant symptoms would have been noted down, or which is the most bothersome symptom should have been on the top of our minds. We should have done a bladder diary and have looked at the bladder diary, and we should have instituted conservative measures according to what the case is. They should have been started, and the patient should be compliant to the conservative measures. Probably the medicines also should have been started, and if it's still not if the symptoms are still going on, then we would do a urodynamic study.
What are the commonly performed urodynamic tests?
Okay, so it is a cystometry, and cystometry, and then measuring of the pressure, the abdominal pressure and the vesical pressure. So abdominal pressure is measured by a vaginal or a rectal probe, and the bladder pressure is measured by a small catheter. And the detrusor muscle pressure gets automatically gets computed by a computer, which throughout minuses the vesical pressure from abdominal pressure from the vesical pressure. That is all I know.
What are the uses of uroflowmetry, please?
Just a minute, Dr. Sidra. I would also like to add to my previous answer of prerequisites of urodynamic test that a dipstick should have been done, and a post-residual volume should have been done, avoided volume should have been done, and a maximum flow rate should have been done before doing a urodynamics. What are the uses of uroflowmetry?
Uroflowmetry, please. Yes.
It gives us a maximum flow rate, which helps us to compute certain figures and deduct, sort of come to a conclusion of what the abnormality can be.
All right. So what are the advantages of a video cystometrography?
Of a video cystometrography? Pass, I don't know the answer.
So how do you assess the bladder function during a cystometry?
During a cystometry by putting a small catheter inside the bladder, and that is connected to a computer. And when it is connected to the computer, it computes the flow rate and also the maximum flow rate, and gives us a trace of how the flow rate, it should be bell-shaped, and that is how it shows. And if it is not bell-shaped, if the second half of the curve is prolonged, then it might be a bladder obstruction, a urethral obstruction, or outflow obstruction. And yeah.
What are the pitfalls that can happen during cystometry?
I'm not sure of the answer. So during cystometry, maybe certain sometimes we would not have taken the baseline pressure, or there can be artifacts on the chart.
Right. So how do you manage mixed incontinence, please?
So in the mixed incontinence, we we will always treat the predominant symptom. So whatever is the predominant symptom is the one that gets treated. As suppose the stress urinary incontinence is the predominant system, as in the symptom, as in this case.
Mm-hmm.
So in this case, she's having a urinary leakage while she's playing sports. Doing sports. So we treat the stress urinary incontinence. So both get treated. It depends on which one is the predominant symptom. In this case, it is stress urinary incontinence. So I would manage according to the stress urinary incontinence. And if it is if the predominant system is of detrusor overactivity, I would manage it as a detrusor overactivity. Do I need to outline the management?
It's okay. Anything you would like to add in any of the question, please? Last 10 seconds.
I can say that when I manage the mixed incontinence, I would, in both cases, whether I'm treating it as according to the patient symptom, if I'm treating it as a stress urodynamic stress incontinence, or I'm treating it as a detrusor overactivity, I would first like to institute the lifestyle measures, which would be losing weight, and in case of detrusor overactivity, it would be bladder retraining. And in case of urodynamic stress incontinence, it would be pelvic floor muscle exercises. So I would do the conservative measures first. And whenever there is a need of any invasive procedure, I would proceed for urodynamics. And then I would decide on what to do with the patient after discussing it with the multidisciplinary team.
So the bell rings. What do you say?
After discussing it with the multidisciplinary team, we would decide on what we do after doing the urodynamics. We have to discuss it in the MDT, and then we have to discuss with and then we have to do the urodynamics. And based on that, we will need to do whatever treatment, whatever is the result interpretation of the urodynamics. But I would treat the predominant symptom first in a mixed incontinence.
Done. Thank you very much. Thank you. All right. How was the station, Jyoti? Urodynamic, a little tough one for you, yeah?
No, I had no idea of video cystometrography, and I mean advantages and disadvantages. I had really no idea.
Yeah. So no problem. I've solved the station. I'll explain that even the urodynamic chart, you were fine in your understanding that it's a mixed urinary incontinence. That was good that you picked it up. Urodynamic is defined as a series of tests that evaluate the function of the bladder and urethra in relation to the storing and releasing urine. The mixed incontinence is the diagnosis in my patient. Number one, that there is an incontinence with the cough, with the leak is there. Therefore, it's a stress urinary incontinence. Along with that, the detrusor pressure is rising. Therefore, it's mixed incontinence on the urodynamic chart. The prerequisites of the urodynamic tests are that we have to do the analysis of the symptoms, the quality of life, the drug history, whether she's taking some diuretic and anticholinergics. We have to rule out prolapse or any pelvic mass or genital atrophy and urinary leakage prior. We have to assess the pelvic muscle tone and any urinary tract infection, if at all it's there, that has to be treated prior to the urodynamic testing. Before urodynamic test, it should be a clear, detailed consent and information should be provided to the patient. A detailed history regarding the symptoms and interpretation of the bladder diary should be done as a prerequisite of urodynamic testing. We have three commonly performed urodynamic tests. One is uroflowmetry, cystometry, and video cystometrography. The uses of the uroflowmetry are to assess the bladder outlet obstruction objectively and to identify those patients who require more extensive urodynamic evaluation than plain cystometry. The video cystometrography that provides an additional information about the bladder anatomy, as the word video tells us, the presence of vesico-urethral reflux can be seen, level of any outflow obstruction in the lower urinary tract, degree of support to the bladder base during coughing is also seen in the video cystometrography. Assessing the bladder function during cystometry, we do it by questioning the patient about her sensation about the fullness during the process. For example, we ask her when did she have the first desire to void, and we see that how much was the bladder fullness at that time. We ask about the normal desire to void. We ask her strong desire to void. We ask her if she has an urgency to pass urine, or if she's feeling some pain during the filling of the bladder. This is how we assess the bladder function during the cystometry. For ease for all of you, I have made two tables for the normal urodynamic criteria so that if at all in exam you're given something away from that, you know that this is abnormal. Less than 8 times per day is a normal frequency. Less than one time or less in night is normal frequency. Polyuria is more than 3 liters per day. Polydipsia is more than 3 liters of intake per day. 1.5 to 2 liters per day is the normal fluid intake. The residual volume, if it's less than 50 ml after passing urine, that's normal. Urethral pressure of more than 90. In postmenopausal, 60 to 90 is even taken to be normal. Remember that the bladder capacity is 300 to 600 ml. The first desire should be somewhere between 100 to 200. If it's earlier than 100, that means that she has a reduced bladder capacity. Strong desire should be around 350. If it's lower than that, that means that it's going towards an overactive bladder. The diffuser pressure during the filling, it should be less than 15 centimeters of water for a 500 ml of urine and less than 10 centimeters of water for a 300 ml of urine, and during voiding, less than 70 centimeters of water. So flow rate, 15 ml per second of volume of 150 ml of urine is taken to be normal. No increased abdominal pressure with the leak during the filling phase, and no diffuser overactivity in the filling phase should be observed. These two tables are for your better understanding, so you know the normal ones, so you'll pick up the abnormal ones, okay? Now, what are the pitfalls during cystometry? The subjective variation in bladder sensation can be there from one time to other. Transducers, they can at times slip off during the urodynamic, and at times the patient may be unable to void in the test condition because of some feeling of being open and not being in a private place. So what is the management of the mixed incontinence? The investigations, we are going to begin with the midstream urine and the bladder diary, as we do for the diffuser overactivity. The first line management covering up both the stress urinary incontinence and the overactive bladder would be pelvic floor muscle exercises and the bladder training, that is 6 weeks it's going to be. You're going to take the history and do the analysis of the predominant symptoms and manage the predominant symptoms first and then come to the other part of the incontinence. If the time allows you at this point, you can manage the SUI and manage overactive bladder according to the algorithms which I've already given to you guys in the Urogyne module, okay? The stepwise algorithm. If time doesn't allow you, you can just tell about this mixed incontinence and your job would be done. All right? Any questions? Anything which you people are not clear about the urodynamic?
Yeah, Dr. Sidra, can I see the graph?
Yes.
Graph, yeah.
Yes.
So one doubt was there. Yeah.
Please.
No, graph, yeah.
Yes.
So the detrusor pressure, yeah, it is raised because I was, here it is 20, 0, 23.
It's going more than 23.
Yeah. So that's what, so,
okay.
Yeah. Thank you.
But Dr. Sidra, there's no leak over here when there is a detrusor increase.
1 leak, 2 leak, 3 leak.
Three leaks are there with cough.
But
One
that
cough,
is with the
two
increase in
cough.
abdominal pressure.
So that's what we're saying, that it's a detusor overactivity and stress urinary incontinence. So it's a mixed incontinence.
But in case of detrusor overactivity, isn't there supposed to be like there is a decreased sensation of first filling, and there is a reduced bladder capacity, but isn't there supposed to be a leak also with
Now
the
in
increase
urodynamic, if it's
detrusor
stress
pressure?
urinary incontinence, at times it cannot be picked up. If you see Oxford station number 1, that says the same. For example, here we have a cough, and for that vesical pressure is raised, abdominal pressure is raised, and there's a leak. If you see here the detusor overactivity is also there, but
Yeah.
we cannot say. So we always say that the leak is there, but if other two are raising, we cannot say that this leak is solely because of stress or there was some sort of a detusor overactivity. So it's mixed. Okay, we cannot pinpoint at this point, because whenever we have lots of up and down in detusor and leaks are there, we cannot pinpoint whether that was because of cough or that was overlapping detusor overactivity in between as well.
Yeah, okay. Yeah, I
All
get
right.
it.
And
Okay,
for
thank you.
Jyoti, for everyone out there, remember that if you're not able to read these, I just want to tell all of you that if you're not able to read this, this is a standard urodynamic chart. First, sweetheart, is always vesical, Jyoti. Second is always abdominal. Third is always detusal, and then there's a flow. This is a
Yeah,
standard chart.
that's what I thought. I was just wanting to make sure before I make any
Very good.
mistakes.
Just want to tell all of you why. Because in exam, at times, 4 lines are given, and this is not eligible. I mean, you can't read this. If you can't read this, don't worry, please. Because first is always vesical, second is always abdominal, third is always detusor, and fourth is always Q. Okay, the flow.
Are the colors
Now,
also standard, Dr.
yeah,
Are the
this is
colors
standard.
also standard?
Yeah, the standard, they're always standard. At times it's a colorless chart like black and white as well. So if it's colored, this is all standard. So VAD, you need to remember WAG. It always goes in this sequence, even if you can't read it, okay? So if I tell, like, I was taking a part 2 session because this time also in EMQ's 2 urodynamic chart were there. In the last exam of September, there were 2 urodynamic charts for interpretation. So I take in detail for them the urodynamic reading. I always tell them that as a rule, there are 3 rules to read the urodynamic chart. Number 1, please see the line number 3 first. Never see line number 1, line number 2. Always see the line number 3 first. If the line number 3 is straight, at least it's not diffuser overactivity. If it's up and down, at least it's diffuser overactivity, then you need to rule out the second thing. So always see as a rule line number 3. I always tell them in EMQ, please see line number 3 first. Now, once you see the line number 3, and you see that it's up and down, so at least it's diffuser overactivity, then you see that do you have a peak of vesical, abdominal, and a Q together. If these 3 peaks are together, 1, 2, and 3, if these 3 peaks are together, that means that it's SUI on urodynamics. So now it becomes a mixed urinary incontinence. So the rule of urodynamic is see line number 3 first, then see the peaks together, first, second, and the fourth one. If it occurs, it is a stress urinary incontinence. At times, it is straight, and you only see this 1, 2, and fourth line as a peak together. Remember, they should be in a row. For example, if 1 and 2 peaks are there and incontinence is there, it is not SUI. Remember, a cough causes a vesical rise, abdominal rise, and then a Q. So then in one row, if it is there, that is an SUI. Please keep a note in exam. Am I clear? Am I clear, everyone? Yeah?
Dr.
So always
Sidra,
see.
yeah, that's clear. But I wanted to ask, if we get a diograph, will there always, like, the cough reflex may be there, but there'll be no leak with the cough reflex.
Exactly.
But will there be a leak when there is no cough and there is an increase in detrusor pressure?
There can be a leak, but there can be no leak, and the diagnosis can be DOA as well. It doesn't mean that it has to be an urge incontinence as well. Diffuser overactivity alone is a diagnosis, my dear.
Okay.
And it can be of 2 types, isn't it? The wet and dry. So
that is overactive bladder. That is on history. That overactive bladder wet, overactive bladder dry.
When patient says that I have to rush to the toilet, but I do not wet myself, that means that she has a dry overactive bladder. If she says I rush to the toilet and on the way I always have wetting, so you say it's a wet overactive bladder. Okay?
But that is not good for the activity.
That is overactive bladder on history. On diffuser overactivity, there's no wet and dry. There's diffuser overactivity as a diagnosis when diffuser is overactive.
Okay, and one more thing, Dr. Sidra, about the pressure readings, those are the standard markings, or because sometimes it may not be
These are
legible.
standard. These are standard as per college. These are standard. I've taken this picture from where? Anybody can pick it up.
Yeah, I think it's strategy. No.
Yeah, that is the talk article, a recent talk article, urodynamic findings. Yeah. Okay. So this is something which is from the college. Strategy has the same. Yes, Jyoti, it has the same. Just to tell you guys that yesterday, the January talk articles were also published. Very good topics they are. I uploaded in the drive of you guys. You people have the drive, right? All the curriculum together in your study.
Yeah.
I've uploaded the January 21 talk articles. 6 talk articles were published yesterday. So I have downloaded them and uploaded there. Okay. Just for your information, if somebody wants to see.
Thank you. Thank you, ma'am.
No problem. No problem. Actually, these talk articles are hard to find specifically now in these situations, but I expect that 1 or 2 structured discussions can be there. So there are wonderful topics like 5 or 6, but at times you can just, when you're free, you can just download them and give a read, because few wonderful topics are there. So you can just keep yourself updated. I always have to make my points, because I have to make their summaries and then I have to update my data for the part 2. So I'm always in habit of reading them quickly and to take out the points which are like the updated recommendations or something which is changed. So this is actually the requirement, because I have to keep myself updated. But for you guys, I'll tell you guys that it's structured discussion, if at all it can be. So I've given that in your drive. Okay. All right. So any other question, please?
Dr. Sidra, do you know the stations which came in?
Yeah. Yes. I have the 14 stations. Actually, the student, 2 students of mine who just appeared, every station was a repeat station. There was none of the station was a new station. But I've asked you to give me detail, so that I will add in the same PDF. I'll add it for you guys. Okay. Just give me 2 or 3 days. She'll send me the details. She gave me the topics, but I wanted her to write down the details so that I can just add in the PDF and give it to you guys. Like we discussed the renal transplant, the same station of the structured discussion, the ditto same station that came. So it's gonna be.
I heard it was all the stations were very straightforward, but that doesn't mean that the competition was lesser.
No. The problem was, Jyoti, the problem was what she was feeling was, the problem was that they were having lots of problem in terms of, like, she was doing a station and from the screen the candidate instructions, they just vanished, and she had to request, where's my candidate instruction, please put it here. Yeah. So somehow in the middle, she said that in my 4th station, there were 3 in a circuit. So the third, somehow there was some sort of a mixing, and the third student candidate, she entered into the same room. So then they were like, oh, stop it, please. And then she had to redo. So out of 14, they had to redo around 4 or 5 stations. So that's a little nervousness was there in terms of like, okay, you start again, and you start the station again. And
I think it's not very good. I heard so also.
So actually, to tell you honestly, I was not saying that in my open group. To tell you honestly, they were saying that this won't work for longer. At least this time it didn't work. They were all like, examiner at times they were not there. They said, okay, I'm coming again. So there was a little in few stations they had to, at times the candidate instructions just vanishes from the screen. So these type of problems are there, but probably they were doing for the first time. Hopefully the March thing would be a little better. But
this
now,
I think this is just a basic, it's just a formality to take the exam, because these are all ST5s who have already been promoted.
Exactly.
Without the,
yeah.
So these were the urgent ones whom they took in January. So I think all of them will pass.
Yeah. Hoping for the same. So I was just talking to 2 of my, in March also 2 of the students, they're appearing. So let's see what
is not urgent. These are the ST5s who are taking the exam.
Yeah.
They have not been promoted to ST6. They are not due for promotion to ST6.
And they are also 150.
There is no urgency. I think some may fail from there.
Yeah, 150
But
candidates are there in March.
yeah,
They were
one
only 28 here.
January exam, everybody will pass.
Yeah, hopefully, yes. We'll give you the good news as soon as the result comes, and we'll give you guys the stations as well. Okay, so don't worry.
Dr. Sindra, any idea when the international candidates will be called for the
Yeah,
exam?
they said that after March, if it works, it's going to be open in 3 months before. A few of the students, they received an email to the query as well. They said just 3 months before May, we will open up the exam.
Okay.
So now college is under pressure as well. See, 17th February is going to be the result of my part 2 students. So it's going to be a second part 2 exam without any part 3. So lots of backlog. I mean, it was February 2020, then September 2020, and then January 2021. 3 part 2 exams and none of the part 3. So the backlog is like rising up like anything. So
Yes.
definitely they're under pressure as well to just pass the older ones so that they can get the newer ones. So let's hope for the best.
But
So
I got news. I think they have said that only they said that the aim would be to go back to a face-to-face exam, but they've said I think only the UK non-trainees, something like that. I'm not 100% sure about it
what
though.
I'm feeling is, Jyoti, that after March they would do something because they'll be in a better position than how we are going to handle. At at the moment, of course, it's not possible to accommodate lots of people, but let's hope that if May opportunity online we get that is going to be a golden opportunity, just clearing the exam sitting at home. So if you get that,
Finally, a lot of people get vaccinated. I think we should move to a face-to-face exam by then. It may
let's see.
happen.
I think it would be 2022. They will be in a position to go back to the circuit. So 2021, I think that it would be an online thing because it would be difficult for them at this moment. But let's see how the things they go, how they decide, and let's hope for the best.
Ma'am,
So
will you keep our recordings till our exams are
yes,
there?
yes, my dear. That is with you guys. Okay,
Yeah.
so don't
Thank
worry
you.
at all.
Thank you.
All right, all
But
right.
all the other specialties are doing their exams like virtual. They did not skip any exams except for the RCOG.
Yeah,
All the
true,
other specialties
true.
did their virtual exams.
Anesthesia had it, pediatrics they had it, and even the psychiatry people they had it.
Radiology had it.
Yeah,
Orthopedics had it. There
exactly,
is
exactly.
no
True.
other specialty waiting like this.
All right. So for you guys, it was Friday today, right? So it's gonna be, when would be the next class planned? Mm, mm, mm.
2
All of
weeks
you?
later on a
2 weeks
Saturday.
later. Okay. So that would be oncology M267. Okay, I'll just give you 2-3 dates in the study group so that you people can decide out of that. Okay, right? We'll just show that and we'll discuss this. So it's going to be subfertility, please. In subfertility, there are stations regarding the stations. It can be a male subfertility or the female subfertility. The introduction, agenda, history. History of presenting illness, primary subfertility is there. You take the partner history in terms of how far they had been trying to get the baby, the pregnancy. In relation, they had been for how much time and living together. Did they try any contraception or were they planning it? No contraception was being practiced. Always do signposting before the coital history. I need to ask you personal questions regarding your sexual life. Is it okay with you? May I know the frequency of intercourse and any problem during the intercourse? And do ask about her cervical screening history. Regarding a menstrual history, if at all, there is a female cause of subfertility, and if you don't know, you have to ask rather P4T2D was my mnemonic. Rule out polycystic, PID, premature ovarian failure, prolactinoma, thyroid, TB, and drugs. These are the female history questions. One out of each you can ask to know about the causes. Then if it is going to be a male history, if male is fine and the problem is with the female, just ask one single question. Is your partner generally fit and well? That's it. If male is having a problem in the reports like oligozoospermia, then ask about the female partner. Is she generally fit and well? So that's it. Don't go into the complete history of partners. Otherwise, it would take like 7-8 minutes for the history only. Ask about his age, his occupation, any past medical or surgical history in specific, any trauma, any drugs he's been taking, or any sexually transmitted disease. If they had a child earlier, so if it's the secondary subfertility, always look for the tubes. any history of sexually shared infection, use of copper coil, any old history of heavy bleeding after the birth, and how was the breastfeeding. So this gives you the clue for the Sheehan syndrome after the history of postpartum hemorrhage. Do ask them in the HOPI about knowledge about the fertile period, investigations they've done so far, so that you take the story and the management from there. Then you complete your gynecological history, obstetric history, the medical history, the family history, the surgical history, and the drugs and allergy. The personal, social, mental health, do examine the patient and management according to the cause, address the patient's concern, and if at all there's something left, she can ask the question, you can answer that question, and then give a patient information leaflet and tell her about the follow-up. Any questions, please? Yes. Anything? The topics I'm going to post in the study group, okay? About the topics regarding the subfertility which we are going to do. All right. So anything which is left from the previous sessions, we can also accommodate. In 2 weeks' time, I'll just write 2-3 dates, whatever you can decide amongst that, so that you can coordinate with your rota and you can adjust your replacements as well. The live presentation, students, please, I would request that you be available there. Okay. All right. Any questions? Anything you would like to add on? No? Done? All right. Thank you very much. So take very good care of yourself. I'm going to post the day for the next session and we can decide amongst that. Please start your activity now in the mini group, distributing the topics rather than doing that just 4 or 5 days before, so that you can work on each topic. Whatever topic we are doing, they are from the exam stations. That means that there are chances that you get a repeat station from this. Okay. Thank you very much, Dua. Thank you, Fawzia. I love you all. Take very good care of yourself. Thank you very much. I would be doing one introduction tomorrow. That will be a free webinar that is actually for my part 2 students. I'm doing ABC of MRCOG3. Though you people don't require ABC because you are in the middle of your alphabets, but still, if anybody would like to join or your friends would like to join, I would share the Zoom link there, okay? But it is generally for the students who have just passed their part 2. They were insisting me, ma'am, we need to take a start. Please tell us how to take a start. So that's basically ABC of MRCOG3 is for them. But still, if somebody wants to join, you people are more than welcome. Thank you very much. Sindra ma'am loves you all. Take very good care of yourself. Lots of prayers from my side. You too remember in prayer. See you guys soon. Bye-bye from my side. Thank you. Bye-bye.